Today we are having our second month session, and what we feel is really very exciting sessions for all of us. I don't know how younger are enjoying, but older people are enjoying much, certainly I can assure you, because the spectrum of discussions we are covering, we are trying to cover, is really as much as possible, as exciting as possible. And the contribution also from the younger people in our last month session in these panel discussions were really so mature and so insightful. Everybody enjoyed. Today we are having, investigational approach. So first we'll start with radiology and lung pathology as ILD, as we all know in rheumatology practices, involves a very major part. And we have with us Professor Somnath Kundu, one of the brilliant teacher in Institute of Postgraduate Medical Education and Research, KOLKATA. And he's now has just started DM Pulmonology in IPGMER Kolkata. He's a founder, chief of DM Pulmonology at this moment, and he's a teacher of last nearly 20 years, if not more, and having a lots of clinical material and amazing input. You will love to have his talk. So far the clinical issues are concerned. Then we'll be having faculty from PGI, Anindita Madam. She will take up the X-ray part, radiology, which is another very important part. And she had a lot of publications in her credit. And we will hear from her how important radiology, interpretation of radiology and MRI in rheumatology practice. Then we'll be having ultrasound session with Professor Parashar Ghosh and Dr. Sumantra Mondal from IPGMER Kolkata, Department of Rheumatology. So this will be really a very useful session. And we have with us Dr. Shapon Pandya, our beloved Secretary of Indian Rheumatology Association. He will deal with the intricacies and critical components. And my part is just to introduce the components. So let's have fun in rheumatology. So for the investigations are concerned. So first we'll have Professor Somnath Kundu.
A special word of thanks to Professor Alokendra Ghosh for including me in this meet about how to approach HRCT in interstitial lung disorders. To the rheumatologists and also postgraduate students, seniors, and again I would like to thank the Indian Rheumatology Association before starting this interactive session. Straight away, we'll be focusing on 4 major aspects. 1. Why HRCT in interstitial lung disorders? 2. How to prescribe an HRCT? 3. The signs and patterns interpretation in HRCT and its clinical application. The thing at the corner there, the view box. This is the most important point when you look at the HRCT. Please don't look it against the natural light. Use your view box. Look at the HRCT plate. So when we say interstitial lung disorder, we mean a heterogeneous group of disorders which affects the interstitium, that is the space between the capillary epithelium and the alveolar capillary endothelium and the alveolar epithelium. And the disease spills to the surrounding proliferation, inflammation, and fibrosis pathologically. Radiologically, how inflammation and fibrosis can be interpreted by using an HRCT. As it is a heterogeneous disorder, so involving a wide spectrum of diseases, but essentially 4 major groups. The idiopathic interstitial pneumonias, the prototype being IPF, the related ILDs, the exposure-related ILDs, the hypersensitivity pneumonitis and pneumoconiosis, the rest
Sorry to interrupt.
disorders, and as we know that the
Before,
X-ray is the
yeah.
X-ray is the first imaging modality of any lung disorder. Look at the four X-rays. One of a connective tissue disease related ILD, the four major conditions, really not much of difference so far as X-ray is concerned. Reticulonodular shadows and slight reduction of lung volume, but you cannot interpret it beyond that. So chest X-ray is a poor imaging tool so far as interstitium is concerned. HRCT is therefore the gold standard because it samples the lung anatomy using thin sections and it achieves maximum spatial resolution. It improves the image clarity, enhances the specificity of interpretation, decreases inter-observer variability, so that everybody actually uses a common language. When I say it is UIP or NSIP, everybody understands that these are the findings that we mean. Therefore, the overall diagnostic accuracy is increased, and many a times we can avoid actually lung biopsy by using HRCT while diagnosing lung. It is a secondary pulmonary module, which is the basic radiologic unit of HRCT. When we say secondary pulmonary lobule, we mean a collection of 3 to 5 alveoli which is bound by the interlobular septum. The interstitium of the lung anatomically comprises the peribronchovascular interstitium, the centrilobular interstitium, the axial components, the intralobular, the parenchymal component, and the peripheral component, the pleural interlobular interstitium. Primary knowledge. What are the points that we must remember when we are prescribing HRCT? When we are doing a conventional CT, we are taking cuts at 5 to 10 millimeters, whereas with HRCT, we are taking thin sections, that is 1 millimeter or less. Classically, or better if we use a volumetric mode of scanning, because it enables us with a multiplanar reconstruction and provides contagious imaging. We usually advise for a CT at end inspiration, full inspiration, and then the breath holding. But sometimes we need CTs, cuts in end expiration, and sometimes even prone image. So when we are prescribing for an HRCT, the requisition must contain a proper history and proper instruction to the radiologist must be mentioned so that really the radiologist understands what the clinician wants, and it is a better way of reporting and a better way of understanding of the HRCT report. Reconstruction images helps us for better clarity. It helps better recognition of the disease pattern and the extent of the disease. This is a coronal image in a case of an interstitial lung disease. Look these two CT cards. What is the difference between the two? The one is showing a concavity of the trachea. In the posterior part, you see that there is a concavity of the trachea. The inspiratory image shows a normal ovoid round trachea, and the expiratory image is the posterior concavity of the trachea, and this is how you differentiate an inspiratory and expiratory image. Why we need inspiratory and expiratory images? Again, look at the expiratory image. Look at those white areas. The white arrows points to areas. The back areas. Look at the corresponding areas in the inspiratory film. It is light there, and the expiratory film is back area. Black. Air trap. Air trapping of expiratory image. In certain interstitial disorders, we'll come to it. Air trapping is a very important diagnostic action, as in hypersensitivity pneumonitis, bronchial conditions, interstitial lung disease. In rheumatoid, you may get it also. So, expiratory film helps to detect air trapping. A young girl, dry cough and Raynaud's phenomenon. and visited a rheumatologist with a CT which shows an ill-defined opacity. We use the term ground glass opacity for this pattern in the posterior lung in the lower field. Just as it was saying whether it is an interstitial lung disease and therefore immunosuppression will be required, workup will be required. The clinician said, well, have a CT in a different way. Yes, hello. So this is the opacity now disappears, and this is actually what is called a prone CT. So the other one was the usual supine CT. When we get the shadow, it was regarded as a disease part, and now on proning, the arrow is showing that the opacity has disappeared. So if we get an opacity in the dependent part in the lower lobes, then we have to differentiate whether it is a true disease or whether it is a gravity dependent density which would otherwise disappear on proning. So this is again an importance of a prone image. So with these technical aspects, with these knowledge in technical aspects, we proceed to the basic science. The first, Honeycomb is defined if you get layers which are stacked upon one another, shared wall. All the words are important. There must be layered sheets, and the walls must be stacked on one upon the other without subtooth pairing. That is, layered sheets stacked upon one another with shared walls is what is known as honeycombing. The prototype of course honeycomb amongst these is rheumatoid arthritis, asbestosis, chronic hypersensitivity pneumonitis, and drugs. Well, these are the four major causes of bronchiectasis or bronchioloectasis. Then we get spaces, but the walls are not shared. So the cystic spaces without it results from irregular bronchial dilatation due to retracted pulmonary fibrosis. All causes that causes honeycombing are usually associated with traction bronchiectasis. We can get traction bronchiectasis also if there is a fibrotic NSIP. We define what NSIP is. Sometimes in end stage of fibrosis, if there is a chronic septal thickening means linear opacities due to interlobular interstitial thickening due to fluids, cells, or lymph. We know that the interstitium contains lymphatic tissues, it contains fluids, and therefore the causes of septal thickening are the Carlisle lines, pulmonary edema, fibrosis, pneumonitis, or lymphatic. The underlying blood vessels can be seen. So you find over there that it is increased opacification with the white dots represents the blood vessels. So ground glass attenuation means increased opacification, not obscuring the underlying causes of ground glass opacity. Ground glass opacity. It occurs in cardiogenic pulmonary edema or in infections, that is Moses xerobic pneumonia. Subacute ground glass opacities in subacute ground glass opacity, increased opacification which you can see the blood vessels, and chronic ground glass opacities which is classically seen in connective tissue disease associated interstitial lung disorders. We get alternate areas of ground glass opacity and hypoattenuating areas. Hypoattenuating areas means areas. And the hypoattenuating areas is what is known as mosaic attenuation. We get it in two conditions. Either it is more black because it contains more air, therefore it is a disease, where you would get associated air trapping if you do an expedited ECT, or it is more black because there is less blood, as in severe pulmonary arterial hypertension. Maybe due to chronic pulmonary thromboembolism, maybe associated with dilated pulmonary arteries, as you can see in the image. So mosaic attenuation is alternate areas of groundless shadows and hypoattenuating areas. If septal thickening and groundglass shadow is associated, that is groundglass shadow plus septal thickening, we use the term crazy paving pattern. So we find here the groundglass shadow is crisscrossed by the lines due to septal thickening, and this is what is known as the crazy paving pattern. The classical cause is pulmonary alveolar proteinosis, but you can get it in cardiogenic pulmonary edema, you can get it in ARDS, you can get it in pneumocystis pneumonia. Consolidation, opacification is there, and through which you cannot see the underlying blood vessels. That is, the underlying blood vessels are obscured. Opacification, obscuring the underlying blood vessels, is consolidation. Causes pneumonias, and from interstitial lung disease point of view, we will highlight on organizing pneumonia caused by vasculitis, connective tissue diseases, post-transplant cases, and cryptogenic organizing pneumonia. Here we use one sign called the reverse sign. You see over there a ground glass shadow surrounded by a dense ring of crescentic consolidation. The dense ring of consolidation surrounding this the slightly lesser dense opacity is what is known as the reverse halo sign, resembles the caudal atoll, and therefore it is called atoll sign. So, presence of a reverse halo sign is seen in a cryptogenic organizing pneumonia. It can be seen in vasculitis, sometimes in cases of sarcoidosis or eosinophilic pneumonia. Nodules are defined as round pulmonary opacities which are less than 3 centimeters, maybe ill-defined ground glass nodules or discrete nodules. Ill-defined nodules, we can get it in hypersensitivity pneumonitis. Discrete solid nodules may be peribronchovascular, maybe miliary nodules, maybe centrilobular nodules with tree in bud pattern, or random confluent nodules with different sizes. Let us look at them one by one. So this is the classical peribronchovascular nodules distributed along the septum, the interstitial septum. And the confluent fissure nodules may present as a galaxy, which is known as the galaxy sign. Peribronchovascular. This was one of our 47-year lady with dyspnea, with skin lesions, with HRCT in all the cards. You see the upper part from the upper lobes and the lower cards, because you can see the bronchus and the carotid. So the first two cards belong to the upper lobes. The lower, you see the ventricle of the heart, so this belongs to the lower lobes. We are seeing peribronchovascular nodules, and this is classical of sarcoidosis. Miliary nodules means 2 to 3 millimeters uniform, randomly distributed nodules. In immunocompromised patients, especially among rheumatology patients who are on steroids, first consider miliary tuberculosis. But again, it may be due to the disease itself, like sarcoidosis, which itself can present with miliary nodules, and often we are in a dilemma whether the miliary nodules are due to drugs or due to immunosuppression and fever. It may be due to other conditions, other infections like histoplasmosis. It may be due to tropical pulmonary eosinophilia, which can present with miliary nodules. Remember, tropical pulmonary eosinophilia is one condition where the patient presents with asthmatic symptoms, rhonchi and wheezing, which is otherwise uncommon in other interstitial lung disorders. Nodules which are larger, nodules which are of different sizes, random confluent nodules of different sizes with masses of fibrosis. This is in complete contradiction to what you saw in miliary nodules. And this person has calcified nodes with a pattern of calcification known as the eggshell calcification of the hilar lymph nodes. Looking at the mediastinal nodes is important in two conditions. Besides this particular condition, it is typical of silicosis. Calcified hilar nodes, random constituted nodules of different sizes with masses of fibrosis, also sarcoidosis, where you must have a look at the mediastinal lymph nodes to find the stage of sarcoidosis. Centrilobular nodules, the clustered nodules, and the classical tree-in-bud appearance. Tree-in-bud appearance means the dilated centrilobular bronchioles filled with either fluid or pus, the bronchial lumens with peribronchial inflammation. Presence of tree-in-bud appearance is not only a very important HRCT feature of tuberculosis, it is regarded as one of the active signs of tuberculosis in HRCT. So tree diagnostic radiologically it can occur in bronchiolitis, it can occur in sarcoidosis, in cystic fibrosis, and allergic bronchopulmonary aspergillosis. So these are centrilobular nodules. So the signs that we have discussed, signs associated with high attenuation, that means more white, the ground glass opacities, that is opacities through which the blood vessels are visible, consolidation, that is through which you can nodules, that is discrete opacities less than 3 centimeters in diameter, septal thickening, that is ground glass opacity plus thickening of the septum, and crazy paging pattern, that is ground glass opacity plus we are getting the septal thickening. The low attenuation got air trapping, mosaic perfusion, that is alternate areas of ground glass and hypoperfusion areas. Cis, we have described honeycombing as multi-layered stacked cis with shared walls. Combination of signs gives that is what is known as a UIP or the interstitial pneumonia. It is actually a histological term obtained from biopsy of the lung. It is characterized by 4 important features. The sine qua non is the presence of honeycombing. So you find over classical areas of honeycombing in subpleural distribution. So honeycombing with subpleural distribution involvement and a heterogeneous distribution that is somewhat patchy with or without traction bronchiectasis in the peripheral part. This combination is known as a typical UIP pattern. It is idiopathic pulmonary fibrosis, may be seen in chronic hypersensitivity pneumonitis, among CTD-ILD inflammatosis, and probable UIP. If you get all the other features, the reticular pattern, traction bronchiectasis, mild GGO, there is no honeycombing. So typical UIP, probable UIP, if you get these features, then it is not consistent with UIP. That is, if the shadows have an upper or mid-lung predominance, if the shadows are peribronchovascular, if there is extensive ground glass opacity more than the reticular opacity, if there are diffuse micronodules, if there are areas of consolidation, if there is extensive mosaic attenuation with air trapping, or if there are multiple discrete areas away from honeycombing, then this is not consistent with our UI. Why is it so important to recognize an UI pattern in HRCT that it eliminates the need for lung biopsy clinical setting of care? We use the term SIP if we get bilateral ground glass opacities with lower lobe predominance associated with reticular shadows and approximate. It is a pattern in connective tissue disease associated ILD. There are some variety of NSIP patterns in CTD ILDs, in systemic lupus, in rheumatoid arthritis, maybe a cellular variety of NSIP. Where there is mild reticular shadows, minimal traction bronchiectasis, or there may be fibrotic NSIP, where reticular markings are coarser, there is more traction bronchiectasis, and there is sometimes there is also associated honeycombing. So cellular NSIP means more inflammation, likely to be more responsive to steroids and immunosuppressants, fibrotic NSIP, where there is more coarse reticular markings, more fibrosis, less inflammation, and even you can get areas of honeycombing. Of capacities in an HRCT. The limitation is that I cannot show the entire CT plates, the 12 or the 24 cuts. So these are representation. The first one showing a peripheral distribution, classically seen in chronic eosinophilic pneumonia. Peribronchovascular distribution, classically seen in sarcoidosis. Upper zone predominant ILD in chronic hypersensitivity pneumonitis, silicosis, and eosinophilic granuloma or Langerhans cell histiocytosis, and the lower zone predominant ILD in IPF. So you've got an idea about how to design what are the basic factors and how does this knowledge translate into clinical practice. We fibrosing ILD and non-fibrosing ILD. A fibrosing ILD on HRCT would be associated with honeycombing, traction bronchiectasis, distortion of the architecture, volume loss, and reticular shadows. A non-fibrosing ILD, on the other hand, would have areas of GGO, that is ground glass, septal thickening, and nodules. So this is a fibrosing ILD. We are getting reticular shadows, we are getting traction bronchiectasis, more reticular shadows than honeycombing, presented to a rheumatologist in a 66-year male patient, joint pain, and the pain was positive. So just as it was thought it could be a connective tissue disease related ILD, the rheumatologist UIP, because it fits into the definition of probable UIP, and because of his age, could it be related to IPF? And then history was taken. This is what came out of the history. You find lots of them deciding over the cornices, and it was a case of long-standing exposure to regions. Remember, one-third of sensitivity pneumonitis. And the Jaipur data that has come out over a study of interstitial lung disease in India from 2012 to 2015 is now showing hypersensitivity pneumonitis as the commonest cause of ILD in our country, as many as 47.3% of cases. So we miss these cases if we do not take a proper exposure history. And it is so important that the ATS ERS in 2018 come out with a motherhood statement that for any newly detected ILD whom you are suspecting that it could be a case of IPF, first take a detailed environmental exposure at work and other places to exclude potential causes of ILD before labeling as a case of an IPF. The differences in HRCT between hypersensitivity pneumonitis and IPF. In IPF, it is subpleural, reticular shadows, traction bronchiectasis. The first four signs for probable UIP, and if it is honeycombing, it becomes a typical UIP. For hypersensitivity pneumonitis, evidence. 6. Reticular shadows, hair pain, and even honeycombing in data. And this combination is what is known as the Hrct sign. Here diagnosis is the clinical profile first. There is very little to say that this CT finding is classical or characteristic of rheumatoid arthritis. This is classical, not like that. So first, history plan. You suspect that it could be due to a CTD ILD if there is an atypical ILD, female, slightly younger age, pleural effusion along with ILD. So you suspect that it could be tissue disease related ILD. Pattern. Organization physiology. HRCT would help us to assess the pattern of fibrosis, the extent of fibrosis, to be able to assess the progression of the disease, plan for therapy, assess the response to therapy, and detect complications. Systemic sclerosis related ILD in early just the basal ground glass shadows, and if it is of longer duration, you get the NSIP pattern more of fibrotic type. You see the esophagus is also dilated, indicating disease UIP pattern can be present in systemic ILD in 25 to 30% cases. There is a method of scoring of fibrosis in systemic sclerosis. Visual methods are there by assessing the nature, either how much it is honeycombing, and the extent. How many lobes, how many bronchopulmonary segments, or how many zones of the lung is involved. And it may be a computer-based DICOM software scoring. The importance of fibrosis scoring is that it gives you an idea about the prognosis of the patient. It correlates with the functional aspects, namely the vital capacity, the FVC, and the DLCO. Young patient, male patient, systemic sclerosis, and nodules, diffuse nodules is all atypical for systemic sclerosis. You find nodules systemic sclerosis, and you just say that it be for history is again important. That this person was a marble stone crusher, and we suspect that this could be an Erasmus syndrome. Rheumatoid arthritis related ILD. This is one connective tissue disease where UIP pattern is more common than the NSIP pattern. Systemic sclerosis is the commonest connective tissue disease where interstitial involvement is common. NSIP was the commonest pattern. In RAILD, the UIP pattern is more common, especially among the males and especially among the male smokers. Now, this is very important because it is occurring among the males, the extra articular features. The arthritic symptoms, before that, the lung manifestations may occur, and therefore they can mimic IPF. So, UIP in rheumatoid arthritis has to be differentiated from IPF. Two signs have been mentioned as CTD related ILD. One is the anterior upper lobe sign. If you get honeycombing in the anterior segments of the upper lobe, this is distinct from IPF. And if you get exuberant honeycombing, the exuberant honeycombing sign in the lower lobes and in the upper lobes. If you get exuberant honeycombing in the upper lobes, then it will be clue that it could be honeycombing, the UIP pattern may be related to rheumatoid arthritis. NSIP pattern is organizing pneumonia. So rheumatoid arthritis can give rise to a variety of HRCT images. NSIP, UIP, organizing pneumonia. Sometimes you may get centrilobular nodules because of air trapping. You can also get centrilobular nodules and air trapping in rheumatoid arthritis. Sjogren syndrome ILD has a typical feature, a mixture of NSIP with cystic changes. Find the black area, the cystic changes as a pattern or the LIP pattern. So LIP pattern in the background of NSIP is characteristic of Sjogren syndrome ILD. Remember some cystic ILD differential diagnosis, especially in female patients, lymphangioliomyomatosis, where you can get diffuse thin wall cysts with normal intervening lung parenchyma. It can be cysts, lenticular cysts in the lower lobes in the Burt-Hogg-Duke syndrome, which is due to a folliculin gene positivity. In SLE ILD, ILD is much less common than pleural effusion. So ILD is much less common than pleuritis. You can get NSIP pattern, cellular, fibrotic, and SLE can present with fulminant respiratory failure with three important differential diagnoses of nearly the same pathology, that is diffuse alveolar damage, lupus pneumonia, diffuse alveolar hemorrhage, And APLA syndrome, especially catastrophic APLA, can give rise to ARDS. Myositis related ILD, again the clinical profile of the patient is important. Here you are finding HRCT with NSIP, traction bronchiectasis, and also some areas of organizing pneumonia. A young girl with skin rash, myopathy, and a severe dyspnea with rapidly progressive respiratory failure. The skin rash and myopathy was for the last 4 or 6 months and developed severe respiratory failure within a very short period of time and is characteristic of anti-MDA antibody positive ILD. Moving on to vasculitis is an important cause of interstitial lung disorder. And the focus is on diffuse alveolar hemorrhage. The triad, presence of hemoptysis, fall of hematocrit and bilateral alveolar opacities. Remember, diffuse alveolar hemorrhage can be recurrent, and recurrent DAH can lead to interstitial fibrosis and pulmonary hemosiderosis. Such was the story with this girl, a 9-year girl, who had recurrent history of shortness of breath, anemia requiring blood transfusion from 1 year of age, treated by steroids, used to get well, got blood, got steroids, became well. The story went on like this. And she was diagnosed as idiopathic pulmonary hemosiderosis. Till at 9 years of age, she presented with acute renal failure, RPGN, and first time, unfortunately for the first time, vasculitis marker, and in such a large titer, the PRP titer was positive. So suspect vasculitis in the context diffuse alveolar hemorrhage. A female was having recurrent hypothesis the last 7 months. Again, it is showing diffuse alveolar shadows. So ground glass shadows in the history, in the background history of hemoptysis recurrent with fall of hemoglobin, the diagnosis is diffuse alveolar hemorrhage. Again, this was a case of microscopic polyangiitis with recurrent diffuse alveolar hemorrhage. Question about DAH mix, maybe pulmonary edema, maybe pneumocystis pneumonia. Really not much to differentiate on the basis of HRCT between the two conditions. The clinical profile is important to differentiate a pneumocystis pneumonia from alveolar hemorrhage. These were the two cases we thought that it is an undiagnosed ILD, a 53-year female with honeycombing in the upper lobes, or a 44-year male with shortness of breath and ground glass shadows with traction bronchiectasis in both the lungs, more on the left lung, and thought that lung biopsy would be required in these cases. And again, both the cases were found to be microscopic polyangiitis with P-ANCA positive and MPO positive in high titers. So the dictum is, in undiagnosed ILD, always assay an ANCA and look for vasculitis as a cause of interstitial lung disease. Recurrent DAH can give rise to interstitial fibrosis. A 64-year lady, she was a mother of one of our residents. She was having fever for 6 months and developed a shortness of breath for 2 weeks. Thought that this could be pneumonia, multilobar, bilateral, multilobar pneumonias. Reverse halo sign. The urine showed RBC, and there was a strong hunch that it was vasculitis. It was pneumonia with GPA. So besides the patterns in ILD, the HRCT also enables us to look for the complications of ILD. If you get new consolidation, think about infections, drugs, or acute exacerbation of ILD. If you get new focal lesions, exclude malignancy, maybe bronchogenic carcinoma, maybe lymphoreticulae malignancies also. Sjogren syndrome can present with maltomas. malignancy, if you get a focal lesion in the lung, more so if the lesions are localized, unilateral, then suspect that it could be due to a lymphangitic spread of malignancy. So these are the 4 points which highlighted at the beginning. We wanted to learn how to order for HRCT, the HRCT techniques, the fundamental HRCT signs, signs associated with high attenuation, signs associated with low attenuation, the basic HRCT patterns, how does the UIP, NSIP and the LIP look like, what is typical UIP, what is probable UIP, what is fibrotic NSIP and what is cellular NSIP, and we try to show in the clinical context, the clinical examples, how do they look like in the context of idiopathic pulmonary fibrosis, in the context of hypersensitivity pneumonitis, or in the context of CTD related ILD. We'd like to end this session with one quiz for you. A very recent X-ray of a 35-year female so-called ILD. Have a look at the CTs. Look at the dates, 21st of August 2020, and look at the clearing in 3rd 10 2020. Look at the dates for the clues for the diagnosis. Yes, diagnosis fibrosis, and it was treatment due to prednisolone and pirfenidone. So I'm sorry if I was not audible at some time, but the key message is identify the HRCT pattern and always interpret it in HRCT plate. I couldn't show you the entire HRCT plate. I only showed the section. This is the virus, but when you get the entire HRCT plate, get the proper history, identify the pattern, and interpret it in the clinical. Thank you very much.
So one of the questions is, sir, how do we differentiate between UIP and fibrotic NSIP? That sometimes becomes difficult for us.
If you are looking at the CT plates, if it is UIP, if it is a typical UIP, there will be honeycombing. Honeycombing may be present in fibrotic NSIP, but not profuse honeycombing. More of reticular shadows, minimal GGO, but UIP pattern will be characterized by honeycombing, subpleural distribution, and of course the history is very important, whether it is an IPF, whether the setting is a CTD-ILD, but more honeycombing would favor UIP rather than a fibrotic NSIP. A fibrotic NSIP would be having more reticular shadows, honeycombing at places, traction bronchiectasis, but really it will be very difficult to differentiate a probable UIP from fibrotic NSIP. You have to judge how much of GGO, how much of reticular shadows, how much of honeycombing is there, and who is the patient, who is the subject. Is it a probable IPF case? Is it a probable case of CTD-ILD? For example, if it is a young female, say a 33, 36-year-old female who is a case of a connective tissue disease, we are not, the balance will not favor UIP. It will shift over a fibrotic NSIP.
Okay, sir. Thank you. The other question is that how frequently should we do HRCT in these in our patients?
Monitoring, go for pulmonary function states. You see, we should go for the functional status, the FVC, the DLCO. We can do an HRCT to find out the changes, say at the end of, if you depend on the regimen, supposing if you are using say pulse cyclophosphamide, you do it at the baseline and you do it at the end of treatment.
So PFTs and probably annual HRCTs. Can we do HRCT once a year if the PFTs?
You can do an annual HRCT, say a case of rheumatoid arthritis is there or a case of PSS is there, and you want to see the progression of the disease, then you will do an HRCT, and also you will have to combine it with the functional status, that is with PFT. PFT is more important.
So the functional test is more important.
Yes,
one of the questions was how do we differentiate between pulmonary edema and ground glass if the heart size is normal on the HRCT?
Now, if you get an HRCT there, pulmonary edema, say a cardiogenic pulmonary edema, look at the heart size. That is very important. The classical teaching is there in pulmonary edema due to cardiogenic cause. The shadow is more from the apex to the periphery. The battling appearance is there. The clinical setting is important, and cardiogenic pulmonary edema, actually, you don't do HRCT in most of the conditions. You don't require it unless it is a chronic pulmonary edema. Results with diuretics, the clinical aspect, the clinical setting, the shadow, airspace disease, the batwing appearance from the center to the periphery, and disappearance with diuretics. These are the three important features characteristic of a cardiogenic pulmonary edema. If you are speaking of ARDS, non-cardiogenic pulmonary edema, then of course the ARDS has its own settings and the HRCT findings.
Right, sir. So the last question is, when do you order the HRCT in the prone position, in all patients, or only when you see that particular shadow down there?
You are not present at most of the times when HRCT is done. The clinician is not present at most of the times when the HRCT is done. But when you find an opacity in the lower lobe, in the graph, especially in the posterior part of the lower lobe, and you are in a doubt whether it is due to a disease or it is just because of the gravity dependent density, you order for a prone CT. Number two, if the patient cannot take a deep breath,
Right,
then
sir.
again, if you do it on proning, the shadow becomes more clear. Sometimes on proning, the shadows become more distinct in case of an interstitial lung disease. The primary indication of proning is to differentiate the gravity dependent densities from true disease, especially in the lower lobes.
Thank you, sir. I think with that, I must thank Kunal Chandavar, Prashant Chotaria, and Nayantra Soshenoy for the questions they've asked. We'll move on. There are some other questions which I'll email to you later. We'll move on to the next session. I'll hand over to Alkindu, sir. Thank you, Professor.
Thank you, Somnath. It was wonderful talk and full of information and more of clinical utility. To our next session, interpretation and X-ray and MRI in rheumatological disorder. We have with us for this talk Dr. Anindita Sinha. She is at present additional professor, Department of Radiodiagnosis in one of the most prestigious institute, PGIMER Chandigarh. And she was also trained from another prestigious institute, AIIMS New Delhi. She will be having a wonderful session. She especially is interested on musculoskeletal imaging and intervention. So rheumatologists will be really benefited from her talk, and she had nearly 50 publications on her credit and also around 12 book chapters. So I request Dr. Anindita Sinha to start her talks.
Thank you very much, sir. It is indeed a great honor to be invited by you, and I hope I do some sort of justice to this talk in this next 1 hour. So, to start off, about the interpretation of X-ray and MRI in rheumatological disorders, and interpretation, of course, why we need to do imaging is there are lots of areas where we do imaging. One of this is in diagnosis and management. For diagnosis, mostly the mainstay for us even now is the routine radiographs, and for management purpose you need to have some modalities which are more sensitive in picking up abnormalities early or changes in the management, which will cause changes in the management early. So firstly you need an imaging at baseline, and it is normally done routinely, and depending upon the clinician preference or whether you're going by any guideline, you need to know the degree of severity for the activity monitoring as well as for the response monitoring. Also, another importance of imaging is to detect subclinical information, whether the patient is clinically normal, as well as for evaluating the degree of joint damage or whether it is there or not when it is not visible on the routine radiographs. So what we will highlight is what to image with. X-rays, I think ultrasound will be discussed later, and we will be mostly discussing X-rays and MRI. The first half will be on X-rays, and then gradually we'll move on to MRI with a spattering of CT somewhere in between. So right on, how do we interpret? For a radiograph, for routine interpretation, whether it's the hand, the LS spine, the whole spine, or the large joints like the knee, shoulder, we go by the ABCDs. And the ABCDs, first of all, are the alignment. So are these bones normally aligned, or are there any subluxation or malalignment or dislocations, which can occur in advanced stages? And then we evaluate the bone, whether there is any erosion or any osteophyte or any syndesmophyte in the axial skeleton. Now the cartilage means cartilage is not visualized on the X-ray unless it is calcified. So we evaluate the lucent area, which is the joint space caused by the cartilage and sometimes the ligaments over here, like the TFCC within the ulna over here. We also evaluate the density of the bone, the density of the soft tissue, as well as the distribution of the pathology, which is very important in helping us diagnose or give a differential diagnosis of what the disease is. And last but not the least, we should not forget the soft tissue. I don't know whether this is projecting well, but our evaluation should not stop at the bone edge, but also we should look at the soft tissue distal to the bone and by the side of the bone to see if there is any soft tissue swelling, whether there's any calcification, what is the density of the soft tissue swelling, whether it is there, and these can hold some important differentials. So if the density is high but not as good as calcification, it can sometimes be gouty tophi and help us in the diagnosis. So alignment, of course, we can have malalignment, and it can occur sometimes very early in the disease. If it occurs without any evidence of significant erosions or arthritis, you have to think of Jacquard's, or sometimes SLE also causes these kinds of malalignment, and whether there is any subluxation or dislocation or not, like this over here in the first carpometacarpal joint as well as the metacarpophalangeal joint. One caveat when diagnosing subluxations or dislocations only on the basis of X-rays is that X-ray positioning, if the patient has a very painful hand or any advanced arthritis, patient may not be able to position the hand flatly on the radiograph. So we should not overinterpret, but take it along with the clinical details. But over here, you see the patient has placed his or her hand flat on the X-ray. The X-rays are generally a PA position, so the palmar space is placed flat on the X-ray cassette, and over you see that there is subluxation with the middle phalanx subluxating to the ulnar side over here on the second ray as well as the third ray over here. So these are subtle findings that you should pick up. Another finding, which is the density, also helps us in differentiating what the disease could be. So here I have a normal radiograph where you can see this is the metacarpal, and this is the head of the metacarpal. So if you just go by the anatomy, this is the radiocarpal, the radioulnar joint. This is the distal radioulnar joint. This is the space between the distal radioulnar joint, and this is the proximal row of carpal bones, the distal row of carpal bones, and the carpometacarpal joint over here. If you see, there's not much of density difference between the carpal bones and the metacarpal bones, the base of the metacarpal bones, as well as the metacarpophalangeal joints. However, this is actually very subjective, and unfortunately, the density difference that occurs because of periarticular distribution have been often asked, even by various people, how do you differentiate, or whether it's a normal periarticular sort of minimal lucency or it's a periarticular osteopenia. But when you see a stark difference, like in this case, if you see, this is grossly appearing lucent over here. There's a definite difference and a definite gradient over here, and the periarticular osteopenia is quite evident around the metacarpophalangeal joints over here, as well as the PIP joints and the DIP joints. So this is one of the initial findings of inflammatory arthritis, which includes rheumatoid arthritis, and it can also help you differentiate between some arthritic disorders which can affect the hand but do not have periarticular osteopenia, including your psoriatic arthritis, including gouty arthritis, including erosive arthritis, and can help in the differentiation early on. Now, if you see this third X-ray, again, you see that if you see the density, again, some minimal periarticular osteopenia, or you may even neglect it because there is not much of density difference, because if you see, this is just a radiographic projection, which is totally a bit darker than this. So there's, if you see, compare with this, not much of periarticular osteopenia here as compared to the middle of the shaft. But what you see is that over here, there is a lot of erosions, and we will discuss how to interpret these later on. So density again has an importance in differentiating between disorders. So again, another normal periarticular osteopenia in these two cases, where the right and left shows symmetrical periarticular osteopenia, one of the earliest finding in rheumatoid arthritis, where you can see even the carpometacarpal joints have been involved, the intercarpal joints have been involved, and the radiocarpal joints also have been involved. Now, coming to the next portion. If you see erosions, they can be in two areas. One is the marginal erosion at the sides of or the bare areas where there's a synovial reflection, and later on over here you can see that they will go into centrally into the subarticular location. So if there are marginal erosions, again, you generally don't find marginal erosions in cases of subarticular erosions in cases of erosive osteoarthritis, but you will find them in rheumatoid arthritis or in cases of psoriatic arthritis. So again, these are soft pointers which can help you diagnose. So erosions also you have to look at. If you look at the bone, you just make a protocol about how you look at the bone, either from proximal to distal or distal to proximal. So if you go about it from the large joint, the distal radioulnar joint, then look at the joint space and the proximal carpal row. So if you look at the alignment, these form two smooth arcs. One is the distal radioulnar joint forming a smooth arc, and the proximal carpal row forming a smooth arc. So if you follow the cortex, they'll also be smooth, and any difference in the cortical thickness over here can be an erosion over here. And similarly, this is the distal row. So this is the trapezium, trapezoid, capitate, and the hamate with the hook of hamate. And the distal carpal row again forms a smooth arc between the capitate and hamate. The trapezium and trapezoid are not included in this arc. So again, this smooth arc should be well corticated. And again, look at these thin cortical margins to see if you can see erosions within the intercarpal space, which can be early. So over here in this X-ray, you can see that there is a sort of small lucent area. These findings can be very subtle and easily missed if you don't have it enlarged or don't look at it in the proper places where you want to have a look at them. So distal radioulnar joint, radiocarpal joint, the intercarpal joints are prone to having erosions in rheumatoid arthritis. So these spaces should not be missed. Then the carpometacarpal joints. So again, these cortices, there's no smooth arc in this area, but again, the cortices should be well maintained, as should be the cortices in the metacarpophalangeal joints, as well as the proximal and distal interphalangeal joints. So if you see here, there is this absence of the smooth cortical margin on the radial aspect, and then we know that the radial aspect of the bare areas is the most early place where erosions occur. So this erosion over here, again, symmetrically, you can see an erosion over here. Sometimes the erosions may not have a loosened margin, but may be mildly sclerotic, because X-rays is a 2D superimposition, and you can have a sclerotic area due to the 2D superimposition, or due to a secondary osteoarthritis developing, or due to the pathology itself, where you have a long-standing erosion with sclerosis developing, especially in cases of gout. So again, here you see that there is a marginal erosion here, as well as on the third metacarpal, the third proximal phalanx. So changes are symmetrical. There are erosions. So symmetrical erosions involving the carpal bones, the proximal interphalangeal joints point towards the diagnosis of rheumatoid arthritis. This is another advanced case. By this time, you can see that there has been a gross destruction as well as collapse of the carpal bones with erosion. But along with this, you can also see that there is not only erosion involving the carpal bones, but also sclerosis. So there has been collapse, and possibly secondary osteoarthritis also has developed. You can see large erosions on both sides, again symmetrical. The ulnar styloid has become completely eroded off the bone and dislocated. And there are erosions with, now these are called compressive erosions in the bone, where it has become completely eroded, and it is also almost forming a penicillin cup deformity, but this is actually not a real penicillin cup deformity where there is erosion starts from the marginal area and then there is narrowing, but this is due to gross pannus formation and erosion, which is completely thinning the metacarpal heads. So again, over here you can see that the metacarpophalangeal joints and the proximal interphalangeal joints are involved. There is gross osteopenia, symmetrically distributed, and this points towards the diagnosis of rheumatoid arthritis. Now, again, we showed this where there is a lot of periarticular osteopenia symmetrically distributed. So if you go back again and see whether there is any erosion, you will find that there is again erosion over here on the medial aspect of the first metacarpal, as well as decrease in joint space of the PIP joints here. And this is again symmetrical over here along the PIP joints, not so much prominent here, but there is periarticular osteopenia, again pointing towards an inflammatory arthritis. And rheumatoid arthritis is most likely the distribution. So the most common rheumatoid arthritis, what is the distribution like? And which this will help us in coming to a differential or coming to a proper diagnosis. It is symmetrical. The DRUJ, that is the distal radioulnar joints, The radiocarpal joints, the carpometacarpal joints, the PIP joints are the most commonly involved. Osteopenia is periarticular. Periostitis is absent, unlike in psoriatic arthritis where periostitis may be present. Collapse is more common and ankylosis is rare, although it's common in GIA, which we will discuss later if you have time. And psoriatic arthritis, coming to psoriatic arthritis next, the distribution is asymmetrical. So asymmetrical means one hand may be more common, not only more involved, but one ray may be more involved. So this is typically known as ray distribution. So if you can follow this X-ray over here, there is a erosion of the DIP over here, and this is following a ray sort of a distribution. I will show you another X-ray, and this DIP again over in the little finger is again involved. And when you see the DIPs are involved, you can always think of that it almost negate or keep rheumatoid arthritis in a much lower down differential diagnosis. In psoriatic arthritis, unlike rheumatoid arthritis, osteopenia is minimal, at least initially. Later on, due to disuse, there may be osteopenia. Periostitis is fluffy. I'll show you in the next X-ray. And ankylosis is more common. So in this X-ray, if you see, there are erosions, both marginal as well as subarticular, involving the PIP and DIP. You can have the typical penicillin cup deformities. So here, I'm showing you this typical ray distribution. The second ray is more involved. The third ray is also involved, but the first, fifth, fourth, and fifth. Sorry, the fifth has been cut out. The fourth ray have not been involved. And you can see not only is there erosion of the PIP as well as the DIP, but also you can see this linear periosteal reaction. If you look at this thin cortex over here, outside this cortical margin, you can see a solid sort of bone projecting outwards on both the radial as well as the ulnar aspect, and this is the periostitis, which is commonly described as fluffy, but can also be solid in cases of psoriatic arthritis. You can also see that the joint space has been lost, both in the PIP over here, the DIP over here, the joint space is maintained over here, but the PIP as well as the DIP joint space in the uninvolved ray is maintained. And alignment early on may be normal, but if you have arthritis mutilans, which is a rare phenomena, you can get a grossly deformed joint. So in coming to the next, the erosive arthritis, osteoarthritis, this, unlike psoriatic, involves the hand symmetrically. So here you will get DIP involvement more commonly. The first carpometacarpal joint may be involved. Osteopenia again is absent, so it shares some features with psoriatic in the form of DIP involvement. So DIP involvement you can see, but here it is symmetrical, unlike psoriatic. So if you see DIP involvement which is symmetrical, it is not likely to be rheumatoid. Think of erosive osteoarthritis. Sometimes it can be primary osteoarthritis, but it generally is not very symmetrical in both hands. It can be sometimes primary osteoarthritis with Heberden nodes. The CMC or the first carpometacarpal joint over there is involved, and clinically, of course, you can differentiate whether the patient has clinical synovitis, which will help you differentiate between erosive osteoarthritis and primary osteoarthritis. Joint space again will be lost over here. So again, distribution helps us differentiate between rheumatoid arthritis, psoriatic arthritis, erosive arthritis. And in primary over here, what you typically find is this seagull appearance. This the seagull or gull-wing appearance, where the erosion is quite well marginated and appears like a seagull flying. This is not commonly found in psoriatic osteoarthritis and also in rheumatoid arthritis. So in primary osteoarthritis, again, DIP as well as the PIP may be involved. Here you can see that the trapezium has almost become collapsed. There is sclerosis subchondrally. There are osteophyte formations. So these, with this first carpometacarpal joint involvement, absence of symmetricity sometimes, and the seagull appearance will help you differentiate between primary OA as well as the erosive osteoarthritis. Now, I had showed you that arthritis mutilans commonly, not very commonly seen in psoriatic arthritis, but here you see that it almost becomes, the phalanges almost become thin and licked out like a neuropathic arthropathy, and there is a lot of dislocation and disorganization, and this is known as arthritis mutilans, which is a classical finding in psoriatic arthritis. But here you see, unlike the typical late involvement of there is the non-involvement of the carpal bones. Here the carpal bones have been involved, but unlike in rheumatoid, this carpal bone has also become fused or ankylosed. So not only look at the involvement, but the type of involvement. So you would not find an ankylosis like this in the typical rheumatoid arthritis, and this ankylosis is common in psoriatic arthritis. So this also helps us differentiating. If you get a carpal involvement in psoriatic and you find ankylosis in an arthritis, but you find ankylosis in an adult patient, in a juvenile patient or a pediatric patient, ankylosis commonly occurs in GIA. It is less common in rheumatoid arthritis, but is more common in psoriatic arthritis. The diagnostic feature again in psoriatic arthritis, when you find a spondyloarthropathy, you find these non-marginal syndesmophytes, whereas in ankylosing spondylitis, which I will show later, the syndesmophytes are marginal along the annulus fibrosus, but here you can see a linear gap and it projects away from the joint. So this kind of appearance again is found in psoriatic arthritis. So coming to the large joints, when the knee joint is involved, most commonly we see osteoarthritis, but what happens in osteoarthritis is that the joint is asymmetrically involved, and we know that the medial joint space over here. So this is the medial joint space. This is the lateral joint space. The lateral joint space is relatively preserved. The medial joint space has become diminished and almost absent. And there is, if you see the bone over here and the cortex over here, and you compare with this side, there is subchondral sclerosis, and there is a bone sort of projecting from here. So this is an osteophyte, and this is a typical OA. And on the lateral view, we can see that there is a patellofemoral osteoarthritis with decrease in joint space, as well as osteophytes from the patellofemoral joint space, osteophytes and loose bodies within the joint space over here, loose bodies posterior to the joint space. So this is a typical osteoarthritis with asymmetric involvement of the joint, no osteopenia, no erosions. You may find cysts over here sometimes, but these are subarticular geodes, a cyst probably over here, well marginated. These are large, well marginated, and generally have a sclerotic margin. Now compare it with this X-ray over here. What happens is you see a medial joint space reduction, asymmetric, may occur in osteoarthritis. You can have a single joint involvement. The right knee is uninvolved over here. So you would be again thinking in terms of osteoarthritis, but look at the erosion. This is a marginal erosion over here. There's a marginal erosion. There are small erosions here along with subchondral sclerosis. So long-standing rheumatoid arthritis again can have osteoarthritis secondarily, and both pictures can present together. Now here you can see that there is erosion on the lateral aspect also, and if you see, look closely, there are erosions on the lateral aspect, the marginal erosions on the lateral aspect of the lateral femoral condyle over here and here. This is a more typical picture with periarticular osteopenia, almost with complete uniform reduction of the medial and lateral joint space. No, there is no significant erosion that we can pick up on the X-rays, but this is a case of inflammatory arthritis, which is symmetrical. Now coming to the shoulder, again, if you find symmetrical erosions, it can be large, and what you should look for here is that unlike, there is a line known as the Shenton's line, which we typically talk about in the hip, but there's a Shenton's line which is available, should be seen in the shoulder, and this is the line which goes from the inferior margin of the scapula to the glenoid, and the humeral head and neck junction should be coming over here. Over here, you see that the humeral head and neck junction has subluxated superiorly. So this subluxation, along with this erosions, large, marginal, as well as subarticular erosions on both the glenoid surface as well as the humeral head, both sides, but there is again sclerosis, so there is secondary osteoarthritis, so symmetric rheumatoid arthritis with secondary osteoarthritis. But if you don't see erosion, but just see a subluxation with a lot of sclerosis and this decreased acromial-humeral distance, very often you can find that rheumatoid, not only rheumatoid arthritis, but without erosions, you can find that rotator cuff intervals most commonly cause this kind of subluxations. Rotator cuff tears can cause these type of subluxations, and they can often be symmetrical with bilateral rotator cuff tears. So look for erosions carefully. look for joint distension carefully with effusion before jumping into the conclusion that this can be rheumatoid arthritis. Again, another large joint, the elbow, uncommonly involved in rheumatoid arthritis, but again, symmetrical involvement. If you see just large joint involvement, no small joint involvement, with a lot of erosion, with a lot of soft tissue, sometimes you may miss ossification in different areas, but look for them carefully. And if you find these kind of ossifications elsewhere, they might just be a harbinger of crystal deposition disease, and these can also be very, very destructive and mimic an erosive or a neuropathic joint as well. And these commonly involve the shoulders as well as the elbows, and you can get erosive or destructive arthritis involving the radiocarpal joints as well. Now the foot, coming to the foot over here. Again, you see in this, this is a normal X-ray. The projection is a bit, the contrast is a bit different. But you can see over here that if you see the periarticular space, the alignment, there is a hallux in the first toe. Rest of the alignment is normal. There is no periarticular osteopenia. This is the oblique view. And again, you can see that there's no erosion in the tarsal space, the tarsometatarsal joints. But what you see over here is there's a marginal erosion in the first metatarsal head. The fibula over here looks a bit dense, and you can see that along with the fibula, there is a large calcified soft tissue mass. The joint space is preserved. So these are all hallmarks of, and there is a soft tissue projecting over here on the medial aspect. So these are all the hallmarks of a typical location: density preserved, joint space preserved until late, sort of dense ossified soft tissue lesion over here, non-marginal erosion, and this is a gouty, typical gouty arthritis. So again, there are lots of mimickers, and we should not, we can sometimes be flummoxed by them. So here you see an ankle, shows periarticular osteopenia, especially along the medial malleolus. And what you see on the MRI is a lot of effusion, along with what I'll show you here. So here, if you see the post-contrast image, you see that all of it is not appearing bright. Some of it is intermediate signal intensity. So this is the synovium, and this is also thickened. So this is synovitis, and there is erosion over here. And there is also bone marrow edema along the talus as well. We'll discuss it later in details, the talus as well as the navicular. So what I wanted to highlight is sometimes we, this is a mimicker, and this was actually when we did a needle aspiration and needle biopsy. I think this turned out to be a pigmented villonodular synovitis. This is typically T2 hypointense, but here we did not find a typical T2 hypointensity of a pigmented villonodular synovitis. So another mimicker of ankle arthritis, if you see, there's a lot of periarticular osteopenia in this pediatric patient. What you can see and what would appear is that the epiphysis over here may be a bit enlarged with osteopenia, and there may be some irregularity which would point towards a diagnosis of GIA. And there is a soft tissue density in the posterior aspect, which due to an effusion. And you can also see that there is sclerosis and what appears like an erosion in the talus head and neck junction. But there is a central lucency over here, and the cortex over here appears maintained. And here what you find is that this is actually a central nidus of an osteoidostoma with a peripheral hypointense rim and a central hypointense nidus with a lot of synovitis, because this was an intra-articular osteoidostoma. And this can also mimic a Brody's abscess. So a lot of mimickers of rheumatoid arthritis, GIA, including infectious arthritis, including intra-articular osteoidostomas can be there. And this we had done an RF ablation, and this patient was well now. So another common thing that we should evaluate in patients with inflammatory arthritis is the spine, especially the cervical spine, for any atlantoaxial subluxation. And if there is any suspicion, we should not only get a routine view, but also flexion extension X-rays to measure the atlantodense interval. And this is actually the distance between the posterior margin of the anterior process of the atlas. This is the atlas, this is the C1, and this is the C2, this is the dens. This is the dens over here, which is projecting over here. And you measure the distance between the posterior margin of the anterior arch of atlas and the anterior margin of the dens. And anything in adult more than 3.5 mm, and in pediatrics more than 5 mm is considered to be abnormal. More than 10 mm requires surgery. There is another measurement, we'll not go into the details, but this is required for surgical purposes. And here you need a space for the thecal sac canal, and it should be more than 10 mm so that there is no thecal sac compression. So again, over here, we see a pediatric X-ray. Over here, you can see this is the posterior margin of the anterior arch. This is the dens. So the atlantodense interval over here is normal. Another X-ray over here, you see this is the posterior margin of the anterior arch of atlas, sorry. And this is the dens. So there's a grossly increased atlantodense interval. And otherwise, other than that, there is only just some osteophytes in the C5, C6. So nothing other than this atlantodense interval in this patient who had rheumatoid arthritis. And this should be evaluated. Sorry. So another patient of rheumatoid arthritis over here, you see that if you try to marginate the dens, here you can see the cortex of the dens, but from here the dens is not visualized at all. This is the posterior arch of the atlas, and this is also irregular. And what happens is the dens, and over here also you can see that the dens is just seen till here. The dens is not visualized over here, and the MRI shows that the dens has been completely eroded by the pannus, and this will also lead to atlantoaxial instability. Another case, this is actually an unusual case where the patient actually, if you see here the cervical spine and follow it, you can see that there are, what you see over here is that the disc spaces have become decreased, and there is an ankylosis involving the cervical spine. There is an anterior shiny corner sign with some sort of decreased joint space and ankylosis at least happening here in the lower, or progressing to ankylosis lower down. So this was actually a case of ankylosing spondylitis. And these patients are also sometimes prone to atlantoaxial subluxation. And here, this is the posterior margin of the atlas. This is the dens. If you measure this, this is more than 1 mm, and this is also abnormal. So if you're evaluating the entire spine of the patients with ankylosing spondylitis, or especially in long-standing spondyloarthropathies, our evaluation should not stop at the margins of the cervical spine, but also go up to the base of the brain and see whether there is any atlantoaxial subluxation or instability in this area, because these can have catastrophic complications. Now, there are lots of measurements to find out whether there is any basilar invagination which occurs in patients with long-standing GI or rheumatoid arthritis. But common, and most of these are hampered because most of these have measurements from towards the base, towards the bottom of the skull. And if the skull is not properly positioned, you will not be able to see the opistheon or the lower portion of the base of the skull properly to make these measurements. So there is an index known as Ranawat index, and this is a C1, C2 index. And what happens over here is that you join 2 points from the middle portion of the atlas anterior arch to the middle portion of the atlas posterior arch, this straight line, and from the middle portion of the dens, you draw another line perpendicular to this straight line over here. And this straight line should normally be more than 15 mm. And if it is less than 15 mm in adults, this is abnormal, and this implies that there is basilar invagination. And this is the simplest thing to do instead of going towards all the Macrae's line, McGregor's line, the Chamberlain's line, which is very cumbersome, and you don't remember where each line ends and where other line begins. So this is simply done even if the skull is rotated. Now, if there is an early change in inflammatory arthritis, there are other things that we have to rule out. Is there synovitis? Is there tenosynovitis? Is there bone marrow edema more commonly and more importantly? So depending upon whether you want to rule these out and whether they have any clinical implications in your management, you have to choose a modality, and also have a modality which shows you whether there are any structural changes like erosions. So without going to the details, the ultrasound will be covered later. X-ray is widely available and cheap and standardized, but it is insensitive for these early changes. Only specific erosions are present, and sometimes specific only if you get a proper distribution. But for early changes, especially for bone marrow edema, which has a lot of prognostic implications because they show up as erosions later on, these areas of bone marrow edema progress to erosions, and also synovitis, the degree of synovitis can help in deciding or changing the treatment protocol. But MRI also has the drawback of being expensive, not widely available, and time consuming. And although there are standardized protocols which are being developed, they are extremely cumbersome. We have tried it over here and they're time consuming, cumbersome, very difficult to detect by non-practiced observers. And not so we would like to suggest that even MRI is observer dependent, although people in the West, they are more prone towards doing MRI, but it is more specific or more sensitive actually in picking up abnormalities. Now, when you order an MRI, you have to keep in mind that the patient has to be stable enough to lie in this uncomfortable position for at least 1 to 1.5 hours, depending upon what you've ordered. And this position is often not possible in many elderly patients. They move, and any sort of minimal movement completely destroys the purpose of MRI, which is very, very movement sensitive. Now, this is known as Superman position. We have modified the position with a sort of partially recumbent position where we join two hands together and we call it the Namaskar position, which is more suitable for patients who are not stable. But even then, when you are putting your elbows up and your arms up for a long time, many patients are not able to tolerate it, other than also claustrophobia and the other effects of this sound and all these. So these are all the drawbacks of that MRI have. But there are also standardized scoring systems which with outcome measures in rheumatology clinical trials which have come up. There are atlases also which help you in diagnosing the grade of erosions, the grade of synovitis, the grade of bone marrow edema, and based on this a grading is given if it is necessary. But most of all, what we do is see if there is present the degree of involvement and the joints involved and whether synovitis is present or not. So what is the OMERACT protocol which is suggested? You at least do a coronal T1 and a coronal T2 fat saturated, 3D coronal sequence with a dynamic contrast, which is very helpful for diagnosing, but also when you do a MIP, which is a maximum intensity projection, in a one shot, it gives a very clear view of which area has synovitis, which area has early synovitis or is enhancing early, and that has also got prognostic implications. Other than a 3D dynamic contrast enhanced image, where you do rapid sequences of 15 sequences of giving contrast and taking the images, you do a routine post-contrast T1 fat saturated according to the OMERACT protocol. But what it does not suggest, but is implied, you is also do a axial sequence, because you have to rule out edema, you have to rule out erosions in 2 sequences. So you cannot just say there is erosion on looking at 2 coronal sequences. You have to corroborate it with the axial sequences, because there are lots of mimickers which can, in fact, the normal contour of the bone on the MRI can also mimic erosion. So there are edema grades as well as synovitis grades, and I'm not going to do the details of those, but we will show you how to diagnose these. So what is synovitis? The OMERACT describes synovitis as a synovial compartment with increased contrast enhancement whose thickness exceeds the width of the normal synovium, which is a very good definition. But the problem is that a normal synovium is generally not even visible in the MRI. Even if you do a high resolution MRI with the normal 3T sequence, you will not be able to visualize normal synovium. In fact, it is impossible in the small joints. It may be sometimes visible in the, it is visible in the larger joints like the knee and the shoulder, more so if there is effusion, but it's almost impossible in the smaller joints. So this is one of the drawbacks of the OMERACT definition. So synovitis, we generally pick up on post-contrast images as well as the T2 fat sat images. How you differentiate is T1 post-contrast, there will be gadolinium or something written over here, that post-gad images. If it is not written, then look at the TR and TE. The TR, or the time of repetition, or the TE, which is the time of echo, are very low, in the order of, the TR is in the order of hundreds, at the most 1000 in 3T weighted sequences, and TE is in the double digits. So anything where the TR is in the high thousands and the TE is in the hundreds, high hundreds, it's obviously not a T1 weighted sequence. And this is a T1 weighted post-contrast image. So what our routine teaching is that T1 weighted sequences, the fat appears bright. However, when you give contrast, you want to suppress everything. So the fat is suppressed over here and the bone appears dark. And this is causing the synovium over here to stand out. And this is an enhancing thick synovium. And this synovium around the carpal bones, there is synovitis. And you can see that there is synovitis over here and also synovitis on the coronal. And you can see on the axial over here that this is the proximal, the base of the metacarpal, the second and the third. And you don't see any real synovitis in the base of the third metacarpal. And this is borne out by the axial images. So there is synovitis with this contrast enhancement around the second and third metacarpal, not so much in the fourth and fifth, although you have to really go back and see. Now, the other thing that you have to see is that, hold on, yeah. So here again, this is another example of synovitis where you see that there is synovitis along the dorsal aspect. So how do you differentiate between the dorsal and the volar aspect? You see a bunch of tendons grouped together over here along the dorsal aspect. The hook of Hammett is the another marker which helps you show that this is the volar aspect. So this is the flexor digitorum tendons. This is the carpal tunnel, and this is the flexor retinaculum over here. So this is the hook of the Hammett. This is the tubercle of the trapezium, and so this is the volar aspect. And you see that there is synovial enhancement along over here. But again, another caveat is why we need a dynamic is if you wait long enough, the normal synovium also enhances. And although here the distension is too much, and this is not normal synovium, so synovitis can be routinely misdiagnosed or overdiagnosed if you do a sequence which is later. So synovitis has to be done the T1 post-contrast has to be done quickly to effectively diagnose early synovitis where there is not too much thickening of the synovium. So along with synovitis over here, you can see that there is this is the scaphoid, lunate, this is a triquetrum, and there is hyperintensity or osteitis within the lunate as well as synovitis, minimal synovitis, or say grade 1 synovitis at the carpometacarpal basis. Now, this is a sequence where we have not given contrast, and this is the distal radioulnar joint. This is the ulna. This is the radius. So again, if in the proximal section, you see these bony projections on the radius, and this projection is smooth, there are no bony projections. So the bony projections on the radius where it appears like a hillock, this is the Lister's tubercle, this is on the dorsal aspect. So this is how you differentiate. This is the dorsal aspect, this is the volar aspect. There are the different compartments, we'll not go into that, but you see over here that there is a fluid distension. This is not a post contrast, this is a T2 fat saturated image. And you see over here that this fluid, within this fluid, at the margin of this fluid, is this just minimally hyper intense or maybe iso intense nodular area over here. And this is the normal synovium. So this is actually effusion. And the best way to differentiate effusion is ultrasound is best, because if you do a post contrast imaging, again, if you do it late enough, this also will enhance and you'll not be able to differentiate, and all of it will appear like synovitis. Now, this is what I was talking about when we do a dynamic post contrast, and the dynamic post contrast images unfortunately cannot be given because there are at least 1,000 or so images that are generated. But what you can do, what we can do, or what we can generate image and give to the clinician is these images where we combine all the images together, where you can see that the arteries as well as the enhancement of the synovium is picked up very easily. And so this is an early phase image, and this is a late phase image, and you can see that this portion of the synovium is enhancing early. You can also see over here that there is osteitis within, this is the distal end of the radius, and osteitis is picked up incidentally, and there is synovitis on the fifth metacarpophalangeal joints. This is again enhancing early, so there is proximal synovitis, but you can see over here that the PIP joint synovitis over here is not enhancing early. So these are more clinically relevant, that early enhancing synovium is there in this patient. Now, tenosynovitis again has to be differentiated, and what you find is that in tenosynovitis there will be fluid or synovial thickening around the tendon sheaths. So again, this is the ulna. Here, this is the ulna. So this is the radius. We have come to the scaphoid and the lunate. This is just the distal portion of the radius which is cutting it over here. Here you can see the radius, and this is this is what we do in where we combine both hands in a sort of namaskar position, which allows us to compare both hands together. And here you can see that these are the bony projection of the Lister's tubercle. So this is the dorsal aspect, and this is a compartment where the tendons are, and there is fluid within the tendons over here. You can see the second compartment also has minimal fluid, which may be normal, but there is more than normal fluid here. And what you see over here is that this tendon, this is the along the ulna, along the dorsal aspect. So this is an extensor tendon. Along the ulna means this is an extensor carpi ulnaris. This tendon is enlarged as compared to this tendon. So there is tendinosis as well as there is fluid around the tendon. So there is tenocynovitis along the tendinosis. And this is a finding that we often pick up even if everything else is normal. In RA, where there is early RA changes, everything else may be normal, and this has to be evaluated before you just go on to say. Even on ultrasound, we find even if everything else is normal, this is the last thing that we evaluate and see, and then we say everything is normal. And that is that tenosynovitis of the extensor carpi ulnaris is a common finding in early RA. But here again, you see that there is fluid and this minimal, very indistinctly visualized synovial thickening. You can see so findings are very, very subtle on MRI and have to be picked up with practice and routinely seeing these images. Now, what we highlight again is bone marrow edema, which has to be picked up. I've shown you this case before, and you can see that there is bone marrow edema along the trapezium over here on the ulnar aspect of the trapezium, along with some synovitis, as well as you can see that there is synovial thickening over here, and this may be a pannus over here, and you can see that the cortical margin over here is again become is absent. It is completely filled up with an hyperintensity with the cortical. This hypointense cortical margin has to be seen, but again in the MRI it is very difficult to pick up. And again here there is another erosion, so we need to see and evaluate it in two sections. So if you see bone marrow edema and you see a suspicion of erosion, again see the axial. So on T1, this is a T1 weighted sequence, non-fat saturated. Here the marrow appears bright. The fluid anywhere else will appear hypointense or intermediate signal intensity. This is the tendon, a bunch of tendons, not a flattened out tendon. So this is the volar aspect. So this bone should have been bright completely. This is the scaphoid elongated here. This is the lunate and this is the trapezium. Sometimes on axial it becomes very difficult, but you can see here this is the pisiform. So this is just below the pisiform. This is the trapezium here. And you can see that this is in the bone marrow signal here has lost the normal fat signal intensity, and it is hypointense or intermediate signal intensity. And this is the edema, bone marrow edema, how it appears on the T1 weighted sequences. Now, again, another mimicker, as we said that not all things should be interpreted as erosions. Here you see some cysts within the capitate, as well as some within the hamate. This is a distal row of carpal bones. This is a capitate. This is the hamate over here. And you can see they are non-marginal, they are central, they are bright, and they are well corticated. And cysts are very common findings, even incidentally. So before going in and describing that they erosion, see whether they are extending along the margin, whether the cortex is absent or not before we go in and diagnose these as erosions. Although this patient has minimal the effusion as well as some synovitis over here, these are not erosions in this patient. Bone marrow edema itself also can be very minimal in early cases. So here, this is one case where you can see bone marrow edema. It was present only in this second carpometacarpal joint, very minimal over here. Unlike in another case over here where you can see bone marrow edema involving almost the entire row of carpal bones, and this is how it looks like on T1 weighted sequence. This is edema along the proximal row of carpal bones, and you see what I want to show you over here is that this is not a post contrast image, but you can see this is the fat is suppressed. This is T2 weighted fat suppressed. You can see that the fluid is appearing heterogeneous over here. So this is the synovial thickening, and this is how the synovial thickening appears on the T1 weighted sequence. This is the intermediate signal intensity synovial thickening. So whenever you see synovial thickening, or here you will also immediately have a look at the proximal or the adjoining end of the bone, and you can see that the cortex here, which is dark, hypointense, this cortical margin here is absent. So this has progressed from bone marrow edema to erosions adjacent to the radial margin of the scaphoid. Again, here you see this is a minimal edema along the scaphoid. This is the scaphoid, this is the lunate. Some spotty edema along the capitate also. Another florid case where you see bone marrow edema involving the carpal bones completely, and also an erosion which is marginal along the radial aspect, and this is causing decrease of the radiocarpal joint space, and the carpal cortex is completely abutting the radiocarpal joint space. So these are very subtle findings. And here you see this, if you can see, there is a hypointense cortical line. Adjacent to it is a very thin intermediate signal entity line. This is actually the articular cartilage, and this articular cartilage is absent over here. So you can see that there's already been a destruction of the articular cartilage, and these are very, very subtle findings. This has to be picked up. So coming to the erosion, so OMERACT definition of erosion is a sharply marginated bone lesion with a correct juxta-articular location, because there may be juxta-articular indentations which are well corticated or maybe not even well corticated, which can mimic erosion, especially in the small joints. It should have typical signal intensity characteristic with a hyperintensity on T2 weighted images and loss of the hypointensity of the normal context on the T1 weighted images. And it should be in two planes, as I've told you, in coronal and axial planes. We do not generally use the sagittal planes. And a cortical break at least should be seen in one plane. So here, if you see, again, we have the coronal and this is the axial. So this is the scaphoid, this is the lunate, this is the trapezium. So there is some bone marrow edema along the radial aspect of the scaphoid, along the adjoining radius also. What you can see over here is this mildly wavy margin of the scaphoid, which should not be there. This cortex over here is maintained, but again is fuzzy in this area, is fuzzy in this area. So we have to evaluate whether this is present actually or this is just partial voluming due to the thick sections of the MRI or something which we are overdiagnosing. And over here you can see this is the scaphoid, this is the lunate. There is, if you see, there is indentation. This indentation is well marginated. There is absence of the hypointense cortical margin in this area. The cortical margin is seen, is a bit fuzzy here, but otherwise present along the entire margin of the bone. Otherwise, there is synovitis externally and synovitis or pannus formation externally, and there is contiguous erosion along with the cortical disruption, at least in one plane. Now we have confirmed. So this is how we diagnose an erosion. But over here, you see that there is a bone marrow edema, and we had seen some bone marrow edema here, over here as well. And there is bone marrow edema along the lunate, along the dorsal aspect. And we see that there is fuzziness of the cortical margin, but the cortical margin is thinned out and present over here. So here, at least breach in one cortical margin is what you see to diagnose erosions. So again, you can see that here there is synovitis with synovial fluid, as well as these intermediate signal intensity structures. And these are the synovitis or pannus. And this is the cause of erosions over there. This is another florid case, which is easier to diagnose. So you see that there is bone marrow edema with a lot of osteitis and erosion, which is indenting into the ulna. The distal radioulnar joint is another common area for having effusion as well as synovitis over here on MRI. So another mimicker, if you see only the axial here, and I showed you a case very similar where we had this sort of hypointense rounded structure which was mimicking an idus. But look at the adjoining sections. This is going up to the cortex. And here also there is cortical breach here. There is adjacent synovitis with synovial non-enhancing synovium here. There is another erosion well marginated over the dorsal aspect, over the volar aspect of the radius. So there are erosions here. This is actually an erosion which has harbored down with indentation of the pannus. There is cortical breach on the dorsal as well as the ulnar aspect over here. So this is an erosion which has burrowed down into the ulna, and this is should be again diagnosed as an erosion, not as anything else or not as an infection. Okay, again, very subtle findings. So I'm showing you very subtle findings along with gross findings. So here what you see is a subtle breach in the cortical hypointensity. Here again, see this cortex, you can see the hypointense cortex. And here there is a breach. There is minimal adjacent synovitis over here, minimal effusion on both sides. The ulnar cortex is well marginated with hypointensity. There is no such hyperintensity on the other radius. And this is how the sequence helps us to diagnose, because both the hands are placed side by side. The other thing I want to highlight is on when we speak about symmetricity, the diagnosis is generally based on presence and not the severity. So even if the severity is asymmetric, but it is present, or if there's a very minimal presence on one side and absence on the other side, it should not really be diagnosed as asymmetric, and the diagnosis of the disease should not be changed on just the basis of asymmetricity on MRI, because then we'll be misdiagnosing a lot of cases. Because when we talk of symmetricity, the conventional teaching has been on radiographs. So again, another area where we can see that there is this subchondral erosion over here with these areas of erosion and bone marrow edema in the lunate. And if you see that this there is erosion here, but what I mean to say is that if you look at the other central area over here, you can see subchondral cysts. So degenerative changes can also mimic erosions and can have be mistaken for erosions, but you can have to look at it at different planes and see whether they are going up to the cortex in at least one plane and disrupting the cortex in one plane. Again, very minimal bone marrow edema in the proximal metacarpophalangeal joints as well as synovitis. So I think we have discussed this. We'll not go into this much, but again, just to show you the spectrum of cases, T1 weighted images here, which will show the synovitis as thickening, hypointensity, and this is the enhancing synovium, the non-enhancing planus over here, and again the erosions with the cortical breach and the cortical breach over here with the absence of cortex, cortical contiguity, which is a hypointense line which should be seen on the bone marrow, and if you see the bone marrow edema here, bright as well as intermediate signal, and you can see that there is a lot of erosion with this irregular bitten out cortex sort of an appearance involving, this is the lunate elongated, so this is this is the scaphoid which is elongated, this is the lunate. There is a lot of erosion within the lunate over here. So when I was talking about mimickers of erosion, you can have normal findings which can mimic erosion, and these are the nutrient arteries which penetrate the bones, and these are very often taken as erosions when we are initially interpreting MRIs, and these should not be misdiagnosed as erosions. And you can see that why this is not an erosion. You can see that there is a well marginated cortex which is hypointense. The cortical margin is not disrupted. Similarly, this is not marginal at all. This is plumb within the center of the bone. So this is actually a nutrient artery which is going into the bone and should not be mistaken for an erosion. So now coming to spondyloarthropathy, we have non-radiographic versus radiographic axial spondyloarthropathy, but we will where MRI findings are of lesser severity. I don't know whether they have very significant clinical difference, but generally it's in literature it said that there is not much of significance except for some gender prevalence. And there are recommendations for X-rays. Obviously, it's all. I mean, there are SRs as well as Euler recommendations, where grade 0 sacroiliac joint is normal, grade 1 is suspicious change, grade 2 is localized areas of erosion or sclerosis, grade 3 is moderate or advanced erosion, sclerosis, or widening or narrowing or partial ankylosis, and if it's a complete ankylosed joint, it is a grade 4 it is known as a grade 4 change. So what do we generally do for spondyloarthropathies where you have an inflammatory patient coming with a low backache, inflammatory low backache symptoms? The option is between doing a sacral view, which is just a localized view of the sacrum, but the problem is that then you will miss out on a lot of ancillary findings which may be present in the peripheral joint. So X-ray pelvis AP is routinely done, also recommended. But the problem with this is that this SI joint is oblique, and this obliquity causes a lot of misinterpretation in the evaluation of the SI joint. So the SI joint has two components. The proximal portion is a ligamentous portion, and the lower 2/3 of this on both sides is the synovial portion. And this lower 2/3 of is the primary portion because it's a synovial portion which is involved in the inflammatory changes. Now, if you see, what you will often find is that there are what appears to be sclerosis on both sides, but here you see that the joint space is maintained of the lower 2/3. Here again, the joint space is maintained. There is well-defined thin, lucent cortical margin, hyperintense, dense cortical margin. There is no erosion on both sides. So minimal sclerosis sometimes can be mimicked by normal joints because of the obliquity. So we have to look at the joint margin well before overdiagnosing on the AP view, or get a sacroiliac specific joint, either oblique joint or a prone view. Oblique views are more commonly done. But what I also wanted to tell you is that always have a look at it in a logical fashion. So start at least by looking at the lower lumbar spine, whatever is visualized. You may be able to see some ossification in this area, or ossification or fusion of the posterior elements, or a bamboo spine or a dagger spine going along here as well. If that is not present, if it's an early case, you may find some enthesitis along the margins, along the anterior, superior, anterior iliac spines, or enthesopathies within the obturator foramens or within the symphysis pubis. So have a look at the complete ring of the pelvic bones. Look at the ischial tuberosities. Enthesopathies are common over here. Then go on to the hip joint as well as the greater tuberosity to see if there is any joint changes. As we have said, ABCD, again, alignment, bone, whether there is an erosion, destruction, or joint. What is happening to see, that is the cartilage space over here, the distribution of the joint as well as the soft tissue. And for the soft tissue, you have many soft tissues over here. This is one of the fat planes help us to differentiate. So there is a loosened fat plane here, another loosened fat plane here. These fat planes imply that these are linear and along the margin of the hip joint, completely concave superiorly, and this implies that there is no effusion. If there is displacement, there will be effusion. These are one of the earliest signs that you can find of effusion over here. And also, if you have this teardrop, this is a sort of convexity, the sclerotic convexity. This is known as the Kohler's teardrop. So this distance from the acetabular margin again should not be increased, and this generally is increased if there is intra-articular effusion with increased teardrops sign. Another area that you should not miss is the iliopectineal line over here and the ilioischial line here, because you can find subtle enthesophytes from extending from the ischial tuberosity also towards the sacrum on both sides, enthesopathy in the posterior inferior spines, and these margins as well as the bony margins as well as the joints here should not be missed. And we should not just have a look only at the sacroiliac joint and interpret this as normal or abnormal, but have a look at the ancillary findings as well. Now, if we have a doubt, we always get an oblique view done. And over here, you see that there is, as you said, we had seen in there is sclerosis over here. The joint space is more or less maintained. There is no erosion or narrowing. Especially have a look at this lower 2/3 of the joint. The upper 2/3 is ligamentous and very, very rarely and almost not involved in the sacroiliac joint. So if there is no involvement over here and some sclerosis or finding here, this can often be due to mechanical causes and osteoarthritis other than your inflammatory causes. And inflammation, you should look at the lower 2/3 of the joint again, as I said. So here the joint space is maintained. There is some sclerosis. This is triangular. In cases of the age group, which is the reproductive age group in females, this triangular sort of hyper density in these areas represent the osteitis condensus ilii, which is often seen in post-pregnancy. So if we go to this X-ray, again, what you see is here there is if you look at the joint space appears widened. There is sclerosis here subchondrally in the inferior aspect from the inferior 2/3. There is widening of the joint space, some fuzziness of the joint space superiorly. Again, sclerosis over here, widening and some irregularity of this joint space on the iliac aspect over here. So sacroiliitis again. But about the ancillary findings, you see, look at this symphysis pubis. There is sclerosis as well as fuzziness as well as widening of the joint space. Now, look at the other finding. If you look at the other finding, if you look at the hip joint space, here you can see that there is uniform reduction in hip joint space. If you look at the superior joint space over here, as well as the superior, from the superior medially onwards to the inferior has been completely uniformly reduced. So there is an inflammatory arthritis, there is an enthesopathy of the symphysis pubis, and there's a sacroiliitis. Okay, so moving on to more florid cases where you have these irregularities. And what we often forget in our interpretation of sacroiliac joint is that the joint is actually U-shaped. So there is an anterior aspect as well as a posterior aspect. And if you properly evaluated going back, you should be able to see in a properly exposed sacroiliac joint X-ray that there is an U-shaped joint with a lucency here as well as a lucency here. Now, if you see here, just restrict your evaluation to the lowermost aspect over here and interpret it as normal. You will forget to interpret that this joint is appearing narrow. This joint is almost, so this U-shaped joint is going from here backwards and going back here, because it is, so if you, this is just the this is a case of asymmetric sacroiliitis, and I wanted you to show this case, because if you see, this is the anterior aspect and this is the posterior aspect of the joint, and it goes back. So this is how it is interpreted. This is the anterior aspect and this is the posterior aspect of this joint. So this U-shaped aspect should be completely visualized, and what you see is the anterior aspect is maintained, and you see the anterior aspect of the joint space is maintained, and this is what we're visualizing over here. This is a different patient, sorry, this is not the same patient. Anterior aspect over here has been fused. But if you see over here, the posterior aspect of the joint space has been completely fused, is sclerotic. So this patient also has, and this is bilaterally bit mildly asymmetric, but again, this posterior aspect of the joint space, the joint space reduction is there. There is sclerosis, there is irregularity of the joint space, and this is the complete sacroiliac joint, which should be evaluated before you say that everything is normal. Now again, another X-ray over here where you see this fuzziness and irregularity and sclerosis. There is no ankylosis. There's just widening. So grade grade 3, and this over here you can see another patient over here which shows irregularity, sclerosis, and the erosions on the iliac aspect of the sacroiliac joint. Now, in advanced cases, what you see is complete fusion. And what you will see over here is that it is known as a ghost joint. So superior aspect, the joint space is maintained. Inferior aspect, the joint space is completely fused. Here again, if you see, if this joint space has been completely obliterated, completely fused, so you don't see any joint space. So the joint is complete, joint space is absent, and this is known as a ghost joint with complete fusion of the inferior aspect of the sacroiliac joint. A florid case where you see this dagger spine with the ossification of the interspinous ligaments, complete ankylosis of the sacroiliac joints, as well as what you see is the enthesitis as the ischial spines over here with a lot of enthesopathy. So this is an advanced case of ankylosing spondylitis. Now there are again mimickers of sacroiliitis. So if you see sclerosis, especially only on the iliac aspect, joint space being preserved, especially in the female age group, post-pregnancy, think of osteitis condensa ciliae. In an elderly patient, sclerosis, not much of erosions, but subchondral geodes. You can see that these are again not the erosions, it's not going up to margins. There are cysts which are subchondral in location. So these are cysts which are subchondral cysts or geodes. There is sclerosis involving the anterior aspect with the posterior aspect. This is actually a degenerative osteoarthritis, which can also sometimes be mimic ankylosing spondylitis. Another patient where you have this widening. So widening is another feature. When you have these erosions, you will have widening in a ankylosing, in your spondyloarthropathies, axial spondyloarthropathies as well. But if you look at this carefully, not only is there widening of the joint space, not only is there erosion, but the disease is not limited to the joint space. If you look at the entire bone density, the bone density here is 40, is there's a lot of osteopenia, which is not only along the sacroiliac joint, but the osteopenia is extending up to the iliac bones as well. And this is actually a case of hyperparathyroidism, which can also have widening and erosion of the joint space and mimic inflammatory sacroiliitis if you're not aware of the clinical features especially. Another case which you frequently find, asymmetric sacroiliitis commonly, where you may have fusion or ankylosis later on, is tuberculosis, but you will have a lot of synovitis, capsulitis. So the capsule is found anteriorly within the synovial joint. So this is the capsule which has become distended. This is the hypointense fluid within the capsule, and this is the capsule which has become distended and elevated. So routinely you don't see the capsule in a normal portion of the joint, but here this is a capsulitis. But you can find capsulitis in inflammation also. What you don't find in inflammation is this kind of non-enhancing hypointense area. There myositis with abscesses within the The psoas abscess over here, the iliacus muscle is also inflamed. So myositis or asymmetric myositis, along with the non-enhancing abscess, asymmetric involvement of the bone, either in the sacroiliac joint, even in the peripheral joint, there is a large abscess within the psoas muscle, within the iliacus muscle. So this is a typical tubercular typical infectious sacroiliitis, in this case a tubercular sacroiliitis. So coming on to the cervical, the spine in the spondyloarthropathies, what you find typically in the ankylosing spondylitis are these marginal, thin, smooth, contiguous syndesmophytes due to ossification of the anterior, the annulus fibrosus contiguously. In early cases, the posterior interspinous ligaments are also ossified. What you should look for, again, as I said, not stop your evaluation over here. So this is the atlas, this is the dens. The atlantodense interval over here is normal, and there is no atlantoaxial instability. Also have a look at the posterior spinal line, the posterior spinal line, to see if there is any malalignment, because often there are characteristic fractures in cases of these immobile bones, and these can cause dislocations, or even sometimes which may not be visualized in just a routine lateral normal radiograph, because they are stable in one view. But if you do a flexion extension view or even a rotatory view, which are often not done, so these can give you a alternative diagnosis that there may be some subluxation or abnormality. When you see these posterior lines, the spinolaminal lines over here, and the posterior spinal line, they should be normally aligned. This is a typical bamboo spine on the anterior view. The sacroiliac joints are completely fused over here. On the lateral view, what you find is these thin, smooth osteophytes. There may be in the disc ossification, and this ossification is also a common finding, which is idiopathic, can also be found in spondylosing arthropathy. What you often find is that these patients are not diagnosed till a lot of time is spent, and they come with some other pathologies where we are doing CT scans for some other pathology, and these are incidentally picked up. And that is why it is important to look at the CT scans. I mean, not for rheumatologists, I'm sure the CT scans don't come for you for the X-rays, but these are actually for the evaluation of other pathologies. But these are actually CT scans where we have done for a completely unrelated pathology where the patient is not diagnosed, and we pick up these findings of the typical squaring of the vertebra. So squaring of the vertebra is where the anterior vertebra, especially in the lower regions, are actually concave. But here, due to inflammatory erosion followed by repair, these become squared and the anterior concavity is lost. Not only that, you will find that there is sclerosis and what mimics small nodes and spondylodiscitis, and this is known as an Anderson lesion, where this can be mistaken for a tubercular arthritis. But you can see this complete fusion of the bones, the squaring of the vertebra. There is ossification of the facet joints completely, and also some ligamentous ossification posteriorly. So this is a typical case of axial spondyloarthropathy with ankylosing spondylitis with Anderson lesion, which mimics a infectious spondylodiscitis. Now, another case, this is actually a mimicker of ankylosing spondylitis. If you find these flowing sort of osteophytes anteriorly, have a look at where they are, and typically what you find is in the spine, they may be in the dorsal lumbar region, they may be contiguously involving vertebra, in fact 4 vertebra or more, but typically they are found on the right side and they are absent on the left side, and this is postulated to be due to the pulsation of the aorta on the left side, and this is typically found in diffuse idiopathic skeletal hyperostosis, very commonly found in diabetics, and this should not be mistaken for an inflammatory pathology, I mean as a axial spondyloarthropathy. What you will find in the dish is the sacroiliac joint is not commonly involved, is actually a differentiating marker, where you will find that the sacroiliac joint is normal, and if the sacroiliac joint is involved, then you will find these kind of osteophytes, non-marginal osteophytes. Again, think of whether this is a reactive arthritis, especially psoriatic arthritis, but it's generally not found in these kind of non-marginal osteophytes, or claw osteophytes are generally not found in ankylosing spondylitis. Another case of ankylosing spondylitis where patient actually come for CT scan for umbilical hernia. Again, undiagnosed. You can see there's complete fusion not only of the sternum and the sternum, but complete fusion of the anterior anterior syndesmophytes, kyphosis, complete ossification of the interspinous ligaments, the posterior spinous ligaments, the intraspinous ligaments. So again, another undiagnosed delayed case of ankylosing spondylitis, which is unfortunately very common. This patient also has a this anterior wedge collapse with marginal sclerosis and a vacuum phenomenon and a marginal fracture of the anterior vertebra over there. Now, the spondyloarthropathies or the axial spondyloarthropathies, when we do an MRI, we don't also do an MRI. The initial, it's a good idea to not only write, if you're thinking that it's just an inflammatory low back ache, not to write just MRI of the sacroiliac joints, because in that case, what we do is just a localized view of the sacroiliac joint, where we don't do the imaging of the hips. And then thereby we miss out on findings in the hip. So routinely what should be written when you write a MRI is at least one T2 fat sat coronal of the pelvis, which includes the hips, followed by a proper evaluation of the sacroiliac joints, which is a specific separate indication where we just image the sacroiliac joints as well. And I think I have overshot my my time, but I will just stop here. So this will be this is just to show that there is inflammation with osteitis as well as erosions uniformly but asymmetrically involving the right hip joint, and there is also bone marrow edema. So just a few words. This is a normal SI joint, and if you see bone marrow edema, which is the marker for active bone marrow osteitis, it should be more than 1 centimeter in depth or width, apparent in more than one image, or two separate sites on the same image. Because again, there are lots of mimickers, and when do you need to give contrast? When you see this kind of thin hyperintensity, especially in the adolescent age group where there may be a lot of cartilage, you need to give contrast. This is a T2 fat sat, T1 contrast, and again you see enhancement. So this is actually sacroiliitis, which is borne out by the enthesopathy as the posterior the ischium. And in late stages, you will also find fatty metaplasia, you will find sclerosis. But if you do contrast and you see post-contrast enhancement within the joint as well as within the bone, this is actually osteitis and bone marrow edema, and that is active sacroiliitis or active inflammation, and that is what we are looking for. And X-ray also will find shiny corner signs, and these are often mistaken or misinterpreted as modic signs, but you will see these in the posterior margins. Modic changes are generally taken to be degenerative, but that's why it's always a good idea to have an X-ray along with this. They are actually triangular or quadrangular in shape, and these are due to reparative processes which actually are involved in healing of the corner erosions or the Romanus lesion, and this is known as the shiny corner sign, which is seen, and this ultimately leads to the squaring of the vertebra due to reparation, the reparative process, and this typical appearance of the early ankylosing spondylitis, which should not be misinterpreted as just a mechanical low back ache or modic changes or changes of degenerative changes. Right, I think I will stop over here because I have grossly overshot my time, and I'm sorry that this I'm not able to take on more, but I think I will hand it over to the next speaker. So this is just another quiz for the residents. This is an enthesopathy. There is a calcific enthesopathy. Always think of crystal deposition disease. If you see this kind of huge calcification in the Achilles tendon, CPPD or HAD, there is some partial calcification within the plantar fascia as well. And thank you very much. I think we will stop over here.
Thank you, Dr. Anindita. It was a brilliant talk. I think it's a very vast topic given to you.
Yeah,
So maybe I told Argo that maybe we can have a small session, another session somewhere with cases which have or maybe images which have been seen by residents and sent to you, and then we select those and present to her, and she then sort of send it to her, and then she can I think that'll be a better one. We'll have another session. It was brilliant, absolutely. not
Thank
only
you
very
very
good
much.
revision, but also some very good vision on our part, those who are seniors
Thank you, sir.
also. So I think I'll hand over to Professor Alkendu for the next, or Argo for introducing the next two. And then thank you, Anand. That was brilliant. Absolutely.
Thank you, sir.
Thank you, Anindita. It was really
Thank you.
exhaustive, but really full of information. We
Thank
need
you,
to
sir.
have different style of exercise to enjoy that one. Thank you so much. Very
Thank
much.
you, sir.
Thanks. So let's move to our next and last session, and that's another modality, ultrasound examination and utility in rheumatological disorder. We have with us Professor Parashar Ghosh. He's a professor in the Department of Clinical Immunology and Rheumatology in IPGMER, Kolkata. And he doesn't require any introduction in this forum because he is vibrating presence, his vibrating presence in the arena is already been felt by young and old rheumatologists. Along with him, we have Dr. Shumantro Mondol. He is assistant professor in the same department, clinical immunology and rheumatology. And Shumantro is a brilliant hybrid. He is trained in radiology and expertised himself. Now he is already in rheumatology, and he's a consultant and is a faculty in the department. So we'll have a wonderful session. So let's move to Parashar and Shumantro for their presentation.
Good evening to all of you. So the first presentation will be by Dr. Shumantro. He will talk about the nobology and the upper limbs, and after that I shall speak about the lower limbs. So Dr. Shumantro, please.
Good evening, everyone, to all the participants of the IRS Scholars Meet session 2, and this is the last session of the day 1. So in the first part, I am going to discuss about the role of ultrasound in the rheumatological disorders, with specially discussing on the basics of ultrasound machine operation and the image interpretation, and along with the some of the pathologies of the upper limb joints and vascular and structures and muscles. So it is needless to mention that ultrasonography is now become an important part, not only in the diagnosis of certain rheumatological disorders, but also monitoring treatment response and also to for various guided procedure. And ultrasound is now not only limited to the scanning of the joint or periarticular structure, but its field has been extended to image other structures like nerve, vessels, and muscle. The first 3 are the well-known advantages of ultrasound. We all know that, but the major advantage of ultrasound is that unlike X-ray, CT scan, or MRI, where you have supplied with a plate which is taken by someone else, in case of ultrasound, you oneself are the operator and the interpreter. You know your patient, you know what are the problems, and so you can do the ultrasound accordingly in the required part or some area other than the joints. It is also useful for the guided procedure with a very minimum setup requirement. You do not hesitate to repeat it because there is no ionizing radiation. And unlike abdominal ultrasound, no specific patient preparation is needed for the musculoskeletal ultrasound. But before going to the pictures of the normal and abnormal structures, let's have a look what are the basics of machine operation. So these are the minimum requirements what one need to perform in musculoskeletal ultrasound. The foremost one is the USG machine, which should be MSK dedicated with appropriate transducer. And this machine we are using for more than 10 years with good result. Your patient with certain rheumatological or non-rheumatological problems, and most of all, the knowledge that how to operate the machine, how to choose the transducer properly, and how to analyze an image. So in the basics of USG machine and transducer, for the part you are scanning, you have to choose the appropriate preset for the area of interest. In most of the modern machines, the musculoskeletal setting gives you the opportunity to select separate joints, and there are separate settings for the wrist, finger, elbow, etc. So at first you should choose the proper preset, and the 2 basic things, that the depth setup and the gain setup. Gain means the black or white of the image. So let us give an example. This is from an abdominal ultrasound, and this is the left lobe of the liver, where the image is mostly blackish in a very low gain setting. So if any hypoechoic pathology like cyst is present, it can be missed. This where the picture appearing much brighter, so any hyperechoic pathology like hemangioma of the liver can be missed. So you have to adjust the gain optimally to clarify the lesions separately. Similarly, for the musculoskeletal imaging, the left side, you can barely see some of the bones in the wrist joint, and all structures are obscured by the blackish coloration. On the other hand, there is so much gain that below the bones, you are also seeing some cortical lines. So you should not choose any of them, and you have to choose your gain appropriately to rectify the image quality. Similarly, for the depth setup, in the right-hand side image of the wrist, the full wrist is only taking almost 1/5 of the image and rest is black. So it is far away from your eye. And the left side, it is so near to your eye that you can only assess this aspect, that is the radiolunate component of the joint. So you have to adjust the depth appropriately, so it not be not too much far away or not too much close. However, you may take your image too much close to your eyes to detect some minute pathologies here for erosions or some synovial proliferation, etc. Now, the transducer choosing, we usually use a high frequency and linear array transducer for the musculoskeletal examination. It is generally 10 to 12, but if you can increase in further, the resolution will be better, but you can assess less amount of depth. So for superficial joints like wrist, hand, MTP joints, BIP or PIP joints, one can use 18 megahertz transducer, but in a hip of an obese patient or a shoulder of an obese patient, such a high frequency transducer may not get you to the depth view of the joint. So you have to choose your transducer frequency somewhat lower than 18 megahertz. So apart from depth and gain in setting, you have to choose your transducer frequency accordingly to get an optimum image. The most important is the image interpretation, and what we see is the black or white or somewhat between them. This is an image of the wrist. This is the radius, this is the lunate, and this is the capitate bone taken in a sagittal section. This is the tendon. The most brighter part are the bones, and in between are the soft tissues, tendons, and the subcutaneous fat. Now compare it with an abnormal wrist where some blackish color lobulated pathologies can be seen filling the radiocarpal and the intercarpal recess. And this is called blackish in comparison to the subcutaneous fat. So anything when we see in the wrist, its echogenicity or the whiteness or blackishness is compared in respect to the subcutaneous or subdermal fat. So this type of pathology is a hypoechoic pathology, and most commonly these are the proliferated synovium, which is not only seen in the wrist but the other joints. The synovium will appear this type. Another hypoechoic pathology which can be seen in this sagittal image of the knee joint underlying the quadriceps tendon, there are some hypoechoic area in the suprapatellar recess, and this is actually a fluid. So both the fluid on synovium, usually hypoechoic, a clear fluid may be anechoic without giving a signal, mostly black. But it is often confusing that whether it is a synovial proliferation or fluid, and there are some techniques which are applied to differentiate between them. If you compress the joint with your transducer, a synovium is not displaceable, very poorly compressible. And if you give the color flow imaging or the Doppler imaging, a proliferated synovium may show color within it. On the other hand, a fluid is easily displaceable, compressible, and it does not show any Doppler signal. However, this is the common dictum, but according to the grading or according to the age of the synovitis, or if there is particulated matter in the fluid, both the synovium or fluid may become isoechoic. Another important structure which we often evaluate in the rheumatology is the tendons. In the long axis of a tendo-Achilles, the tendon can appear as a multiple closely spaced echogenic lines which are parallel to each other, and this is actually represents the collagen fibers. And when we look at it in the transverse axis, these echogenic dots or lines surrounded by a paratendon or tendon fascia can be seen. So these are the normal appearance of a tendon. However, while imaging a tendon, one should be aware of the anisotropy, which is actually an artifact. So this is the long axis view of the tendo-Achilles, where the tendon fibers are clearly seen in this area, but at its attachment in the calcaneum, it appears totally black, and giving rise to the suspicion of presence of pathology of fluid in it. This is actually an anisotropy. This is the long head of the biceps tendon in the shoulder between the greater and lesser tuberosity. When my ultrasound beam are coming parallel to the tendon, perpendicular to the tendon, it can give back to all the incident rays which is coming to it. So it gives a white color. But if the incident ray is not perpendicular to the tendon, it may appear black. So this is actually an not pathological thing, but it is an artifactual. And so the tip is, when you are performing in ultrasound of a tendon, especially in cross section, tilt your transducer like a heel toe movement, forward and backward. If the black area disappeared, it is a normal anisotropy, but if it persists, then you should give a closer look to detect some tendon pathology. And this is the normal structure of a median nerve in the axial view in the wrist near the entry into the carpal tunnel. There are multiple hypoechoic fascicles which represents the nerves fascicles surrounded by the hyperechoic epineurium. And in long axis, this can be viewed as multiple hypoechoic structures, which are again the nerve fascicles separated by the epineurium. This is the normal structure of a nerve, and other nerves also seen like this. But there is a practical problem. In case of heel, there is no doubt that it is a tendon. But when you scanning the dorsal aspect of the ventral aspect of the wrist in a transverse view, the median nerve is surrounded by almost 9 tendons. And there is some cases there may be difficulty to find out what is actually the median nerve and what is actually the tendons. So there are some tips. The honeycombing is seen in the median nerve. It is more of a blackish and some of the hyperechoic dots. A tendon is more of a hyperechoic dots, less blackish. You can move your wrist, your dorsiflexion or flexion extension. The tendon will move much more than the median nerve. If you tilt with transducer forward and backward, anisotropy will be most evident in case of tendon, but not much more from the median nerve. And lastly, you can move your transducer proximally towards elbow, and after a few distance, you can see the muscle belly will be visible in case of tendons, whereas proximal to the wrist, a median nerve goes deeper and towards the medial aspect. So these are the some clues by which median nerve can be separated from the lots of flexure tendons in the volar aspect of the wrist. And this is the normal structure of the muscle. This is the thigh muscle. This is the rectus femoris. This is the subcutaneous fat, and the most is the skin interface. And this is the muscle fascia, the hyperechoic structure. It is actually hypoechoic fascicles which are separated by multiple long echogenic lines. This is known as the perimysium. A normal vessel is usually demonstrated in anechoic or purely black lumen surrounded by wall. And you can appreciate the 3 layers of the wall, the innermost in the intima, which is a thin whitish line. The medial hyperechoic layer is the medial layer, and the adventitia is again white. And in case of any doubt, you can apply the color flow signal, and unless a vessel is obstructed or stenosed, it will show color flow within it. So these are the basic structures which we evaluate in by ultrasonography in rheumatology, and we use it mainly to diagnose various articular or periarticular inflammatory change mainly, but sometimes you can get some non-inflammatory pathologies also. For the imaging of the vessels, especially for the large vessel vasculitis, and also to rule out DVT in an emergency setup. To determine tendon, nerve or muscle pathology. Very importantly, US-guided procedure where you can give injection or take biopsy very precisely from the desired site. It is not for the identification of a specific type of arthritis that by ultrasound I am saying this, it is rheumatoid arthritis, it is psoriatic arthritis. It is not like that, but it can say that what is the type of pathology, except for crystal-induced arthritis where some pathological feature or specific features are present by which you can say, yes, it may be a crystal-induced arthritis. So we commonly evaluate these following structures like the synovial membrane for its proliferation or vascularity, presence of synovial fluid. In the tendon, we can assess the tenocynovitis or tendon rupture. In enthesopathies, the tendon and ligament attachment pathologies can be assessed, especially for the SPA patients. And some regional musculoskeletal pathologies like DQ, tenosynovitis, tennis elbow, golfer's elbow can be assessed. So in wrist, let us look for the first case. A 43-year-old female with hand joint pain with questionable swelling. She also complains of stiffness and clinical examination does not show much swelling. There she has a borderline high rheumatoid factor, sent for USG of the wrist. And you find some such types of pathologies in the left wrist joint. That is, this is the radius, this is the lunate, and this is the capitate, and the radiocarpal and the intercarpal space is filled with some hypoechoic structures. Let us compare with a normal wrist, and we can say probably this is a hypoechoic synovial hypertrophy. To confirm it, you can compress it with transducer to see whether it is displaceable or compressible. And you can use the power Doppler, and if Doppler signal is seen within this proliferated synovium, it signifies the active synovitis is present in this patient. And we have to grade the synovial proliferation, and there are some grading system. In normal joint, you cannot visualize a synovium. A grade 1 synovitis is just the filling of the two articular tip, but not bulging over it. And it is important to remember that grade 1 synovitis can be present in a significant proportion of grade 1 synovial proliferation, rather in a significant proportion of normal person also. A grade 2 proliferation is that synovium bulging over the recess, and a grade 3 that the synovium extended to the both sides of the bone, forming the joint. So this is actually the grading of the synovial proliferation, and you can also grade the synovial vascularity. This is the grade 1 vascularity, this is grade 2, and this is the grade 3, which is the extreme. And this picture represents a grade 3 synovial proliferation with grade 3 vascularity. Now the cutoff is to define a wrist joint with synovitis, either a grade 2 synovial proliferation should be present with or without a grade 1 PD signal or the power Doppler signal. You can also assess synovitis of the other hand joints, that this is the metacarpophalangeal joint, and one can see the synovial proliferation, some amount of more anechoic fluid within it, and gross hypervascularity in the power Doppler imaging. And this is the same picture, the synovial proliferation and vascularity in the PIP joints. Now this is another case, a 55-year-old male with pain and swelling of multiple joints, numbness of the hands, and the deformities of such type just for last 6 months. Ordered for an USG of the wrist and hand. The wrist did not show much synovial hypertrophy. It can be said that it is a grade 1 synovial proliferation and grade 1 power Doppler vascularity. So it is fulfilling the criteria of the synovitis. But when the Volar aspect was scanned, one can see this type of structure, one mostly hypoechoic structure with some hyperechoic dots within it can be seen in the forearm and the wrist. And it was subsequently found to be a grossly enlarged median nerve bilaterally. The scan plane was increased to assess the ulnar nerve, and it was found that both the ulnar nerves are also increased in their caliber. The patient was subsequently sent to the dermatology department, and acidity smear was positive for the presence of lepra bacilli, and it was subsequently diagnosed as having Hansen's disease. So extending the scan plane from the wrist to the forearm and to the elbow subsequently, ultrasound helped a lot to find a decision ultimately. Both the grayscale and power Doppler ultrasound have good sensitivity, and if you combine these two, the sensitivity is 83.5% and the specificity is 85.23%. It is a pooled sensitivity. For the power Doppler detection of the hypervascularity, a specificity of almost 97% has been reported, and for the grayscale, the sensitivity of almost 94% has been reported. But it may vary because it is a gross operator dependent procedure. Another thing which can be detected by the ultrasound are the erosion, defined as an intra-articular discontinuity of the bone surface, and it should be visible in two planes. This is the long axis view and this is the axial view. The sensitivity is low for the erosion for USG, however the specificity is quite high, and ultrasound is superior than conventional radiograph to detect the erosion early. We can grade erosion accordingly, and it is graded from 0 to 3. Now let's take an example of another 53-year-old male complaining of pain and swelling of the wrist joint, and ultrasound was performed in both the long and the axial view to see this type of features. So this is the extensor tendon of the fourth compartment surrounded by some hypoechoic materials. Some fluid is also seen. In the transverse axis, this the tendon sheaths are thickened, and power Dopplers show a lots of vascularity within it. In comparison to a normal, the abnormality can grossly be appreciated. So it is an abnormal anechoic or hypoechoic thickening of the tendon sheath, which represents the fluid in the tendon sheath and hypertrophy and hypervascularity. It is actually a tenosynovitis. And one can see that in presence of tenosynovitis, the fourth compartment or the extensor digitorum tendons can be easily separated from each other, and which are not seen in a normal person. So this is a practical tip that if you can see them separately very easily, think of presence of tenosynovitis. An old carpenter with right wrist swelling, which is intermittent, and USG was performed to see this type of cystic clear fluid within it. There is no synovial pathology. This is another wrist swelling, and you can easily detect that it is actually a ganglion cyst. However, there is one thing I want to mention, that there are some brightness here, which is not present in the other side, and this is known as the posterior acoustic enhancement. And when ultrasound passes through clear fluid, it causes, as there are little absorption of the ultrasound or little reflection, all they are gathered in the tissue behind it, increasing its brightness. And this posterior acoustic enhancement is another sign by which you can differentiate a fluid filled space from a synovium. And 55-year-old lady with pain and mild swelling at the lateral aspect of the wrist, another wrist swelling in a diabetic patient, and wrist USG shows thickening and fluid around the first extensor compartment. This is the axial view, and this is the sagittal view. And this is actually a deep wave tenosynovitis, and if not contraindicated in the same sitting, USG guided injection into the tendon sheath can be given with a good precision. This RA patient having a disease duration of 8 years is unable to extend the right fourth and fifth finger. Yes, you can place your probe over the dorsal aspect of the tendon to see such type of deformity. If compared with a normal tendon, one can appreciate there is a hypoechoic cleft separating the two tendon bellies. So this is actually a tendon rupture of the extensor compartment of the digits. So these are the mostly articular and periarticular pathologies. Some nerve pathologies, especially the median nerve pathologies, can also be taken care by the ultrasound. This 41-year-old female hypothyroid patient complaining of pain and numbness of the fingers, which is worse at night. Some amount of stiffness is also present. An ultrasound of the nerve shows a grossly enlarged median nerve, almost 19 millimeter square cross-sectional area. The normal cutoff is up to 9 to 11 millimeter square. Interneural vascularity, and there is a definite notch or a change in caliber in the proximal to distal aspect when the nerve is entering into the carpal tunnel. So this is actually median neuropathy. Some other criteria of median neuropathy are also present, which are USG criteria. And if one is interested, this is a very good article published from our institution this year, that the role of high resolution USG in carpal tunnel syndrome, and a criteria was derived also. So to summarize the wrist and hand USG, why we should order it? Either we should want to detect a synovitis or tenosynovitis or localized pathology, and based on the pathology suspected, one have to plan their scan. Normally a wrist can be scanned in the dorsal plane, ventral plane, or medial plane, mostly for the inflammatory arthritis. But if needed, other side can be scanned, or other joints like the MCP or PIP joint can be scanned. And MCP, DIP, and PIP joints are usually scanned in both the dorsal and ventral plane, and all the joints should be scanned in both long and transverse axes to get the optimum result. Coming to the elbow joint, there are 4 scan planes. One is anterior. This is the anterior radial aspect, and this is the radial fossa. This is the humerus, and this is the radial aspect. And one can see the presence of fat in a normal, non-effused joint. This is the lateral aspect, which usually shows the origin of the common extension tendon and the lateral collateral ligaments. This is the posterior aspect. This is the olecranon. This is proximal towards the humerus, and this is the olecranon fossa, which is also normally filled with fat. So we commonly used it to show the ultrasound detected effusion. So this is a patient with a swollen elbow joint. So in comparison to a normal elbow joint, a clear fluid can be visible in the radial fossa, which is displacing the fat pad anteriorly. Similarly, one can detect the presence of fluid in the olecranon fossa, and in this case, this is fluid in the posterior aspect of the elbow joint in the olecranon fossa with a clear displacement of the fat pad posteriorly, and it is covered by the triceps tendon or the long head of the triceps tendon. Another common condition, tennis elbow lateral epicondylitis. This is the normal appearance of the common extensor tendon, but in case of lateral epicondylitis, the tendon or the common extensor tendon becomes swollen. The heterogeneity in the ecotexture appears and it shows vascularity within it. The similar feature can be seen in the medial epicondylitis also, except it can be found in the medial aspect at the origin of the common flexures. Now, this young male with painful swelling of the posterior aspect of the right elbow, and when probe was placed over this region, you can see there is presence of fluid, some amount of soft tissue heteroecogenicity surrounding the fluid. This is overlying the triceps tendon, and there are some evidence of vascularity in this region. So this is actually an inflamed olecranon bursa or olecranon bursitis, which may present like a elbow swelling. The shoulder joint, it may be slightly difficult for the beginners because there are multiple scanning planes. Different arm position are required for scanning the different tendons of the rotator cuff. It is mostly used for the diagnosis of the bicipital tendinitis, subacromial subdeltoid bursitis, presence of minimal amount of joint effusion, chondrocalcinosis, or for some USG guided procedure. So this 51-year-old male complaining of deep anterior shoulder pain, which is aggravated by overhead movement, and USG was done in the anterior shoulder in the transverse axis overlying the long head of the biceps tendon. And one can appreciate that the long head of biceps tendon is surrounded by echogenic thick materials with some amount of fluid in it, in contrast to the normal long head of the biceps tendon, and there is color flow within it. So this is actually a bicipital tendinitis. In the same sitting, a USG guided injection into the tendon sheath can be given. Minimal amount of shoulder effusion may not be obvious by the clinical examination. In that case, the scanning in the posterior glenohumeral aspect can show minimal amount of effusion. This is almost hypo to anechoic fluid in contrast to a normal posterior glenohumeral joint. And if the fluid is really minimum, the external rotation of the shoulder can cause bulging this fluid to become the effusion more prominent. 65-year-old male with recurrent attacks of pain and swelling of the shoulder and knees, but now in the asymptomatic phase. To see the shoulder pathology, if you perform a shoulder USG, some pathologies are there in the cartilage of the humerus, and there are some amorphous deposit of the crystals within the cartilage substance. It is actually chondrocalcinosis, which is usually seen in CPPD. And a diabetic female with pain and progressive restriction of the shoulder movement. This is the normal structure. This is known as the rotator cuff interval. This is the area between the supraspinatus and subscapularis tendon, where the long head of the biceps tendon lies, and the coracohumeral ligament goes above it. So in this rotator cuff, there are thickening of the soft tissue and appearance of the vascularity suggested an inflammation. It is actually adhesive capsulitis, which is very common in a diabetic female. So now let us move to some of the vascular pathology. It is USG, the major role is for the large vessel vasculitis and also to rule out DVT. A young female with lower limb claudication and lower limb pulse and tenderness over the carotid arteries, and USG of the carotid artery done. This is the USG image. If we compare it with a normal carotid artery where a very clear lumen can be seen, and this is the wall thickness, in comparison to this patient have a gross homogeneous thickening of the entire carotid wall with compromisation of the lumen. So this is most probably a large vessel vasculitis or Takayasu's arteritis. Or in an elderly male with low-grade fever, weight loss, and headache, and superficial temporal artery was scanned to see this type of finding, that is the lumen is compromised by the hypoechoic thickening of the wall, which in comparison to the normal, this is actually what is known as the halo sign. The cutoff values for the significant wall thickness for the superficial temporal artery, it is 0.42 millimeter, and for axillary artery, it is 1 millimeter. So in giant cell arteritis, this halo sign has a high sensitivity, not so much, but specificity is almost 96%. And in Takashi arthritis, ultrasonography have greater sensitivity than conventional angiogram or MR angio, especially for detecting of the very early wall thickening of the common carotid arteries. Now, if this patient is also complain of shoulder stiffness, arthralgia, you should move from the carotid to the shoulder joint to see you may get this type of finding, that is actually the subacromial subdeltoid bursa. In comparison to the normal bursa, there is proliferation of the bursa with fluid and it become convex shaped. So it is actually a SSD bursitis. And so we can now consider the diagnosis as the patient is having giant cell arthritis with PMR. Now these last two, a 26-year-old lady with acute onset pain and swelling and redness of the right forearm. We commonly think of two pathologies. This is the first one. This is actually thrombosis of the right axillary vein. We can see the echogenic material filling the lumen of the axillary vein and very poor flow of blood within this obstructed vein. So in this case, if this patient is especially APS positive, we need to start anticoagulation immediately. On the other hand, if the veins are looking normal, then one should look for the other pathologies, and it is not so uncommon that one can get this type of pathologies. So this is actually the forearm muscle. This is the flexor digitorum superficialis of a normal person. And we can compare, there is some gross abnormality of the FDS in this female. There is loss of the normal myoarchitecture, hyperechogenicity, and presence of fluid. So it is actually myositis. So in that case, an antibiotic would help rather than anticoagulation. There may be some future application, like we can use USG for the skin. This is actually image from a derma scan. It may be helpful for patient with systemic sclerosis if we can add elastography of the skin along with the normal USG. You can also assess nails, and we have already published the abnormality of the nail in psoriatic arthritis previously. So in future, the role of USG may not be limited within the joint or periarticular structure or muscle or nerve, but many other structures can be evaluated. So to conclude, ultrasonography offers some added information to the clinical examination. It is useful for both articular and periarticular pathologies, especially for large joint where minimal effusions may not be detected by the clinical examination. It can be repeated easily, and USG-guided procedures can be done in the same sitting, which is another very major advantage of the ultrasonography. Thank you.
Again, a very good evening to all the participants. As I speak about the ultrasound abnormalities in the lower limbs, when we think of ultrasound, we should think ultrasound as an extension of the clinical examination. So when a patient comes to us, we should examine the patient clinically, because we are very strong clinically. And if you have any questions which is to be answered by ultrasonography, then you can answer. We can do ultrasonography. Let me start with ankle pathology. So there are the pathologies that we look for in the ultrasonography: the arthritis, tenocynovitis, tendinosis, enthesitis, bursitis. Others like ligamental injuries we do not see. Basically, they are seen by the orthopedic surgeons. And this is a patient who presented with ankle swelling. And this ankle swelling can be because of ankle arthritis, can be because of tenosynovitis involving the medial or lateral tendons. There can be retrocalcaneal bursitis or tendoaculitis. Retrocalcaneal bursitis and tendoaculitis is easy to and it's a little bit different because patient have got swelling in the back of the heel. But ankle arthritis or tenosynovitis may be difficult to understand, be difficult to differentiate, especially when there is damage to the ankle joint, and also it's difficult when there is swelling of the subcutaneous tissue. So when there is pitting pedal edema in that setting, how much is because of arthritis, how much because of tenosynovitis, it becomes difficult. So this practical example, so this is a patient of rheumatoid arthritis. He is having this is the photograph of the ankle. They're not very well taken, but it seems that there is swelling, bilateral swelling is there. It might be that on the right side there might be some amount of postotibial and peroneal tenosynovitis also. We cannot be sure, and that question can be answered very easily by ultrasonography. Similarly, in this photograph of the ankle, the right ankle joint seems to be swollen, or may not be swollen. There is doubt is there. As a resident, I always had problem, and now also I had a problem understanding whether ankle swelling is there or not, and that can be answered very easily with ultrasonography. The lower one is the normal sonography of the ankle joint. So this is the skin, subcutaneous tissue, and this is the whole length is the tibial is anterior tendon, and then usually there is dorsal aspect artery in this photograph. It's not there, but this is the talus, and this is tibia. Between talus and tibia, you have got ankle joint, and this is the cartilage. The black one is the cartilage. If there is effusion here, you can you see the cursor? So if you see this effusion, it will be black. So this black is basically cartilage. It is not compressible, but this black, if you compress it, you can compress it, and it is compressible. And if you give color, it will not take up any color. It is a vascular structure. So in this way, we can differentiate the cartilage from the effusion. But when you get effusion, you get a lot of black area here. So very easy to diagnose ankle arthritis by ultrasonography. Another picture. This is lower end of the tibia. This is talus, and then you have got the effusion here. So ankle effusion, it's a bit easy with ultrasonography. Now coming to tenosynovitis, on the lateral aspect of the ankle, below the fibula, there are peroneal tendons, peroneus longus, peroneus brevis, and when you do ultrasonography in this region, we get this peroneal tendons, peroneus longus, this is peroneus brevis, and we get fluid around it. So this is nothing but peroneal tenosynovitis. That can be, and we can give injections also. So when you give injection, USC guided, we can give wherever there is fluid, we can inject there. And this is the normal peroneal tendon, this one. And normal peroneal tendon, peroneus longus and brevis, they are very close by. And there is a septum, only septum there which separates them, and sometimes they may not be visible. So the peroneus brevis is near the bone, and the longus is this one. So it looks like a single tendon sheath, but it has got two tendons. So this is the pathology, peroneal longus, peroneus brevis. So when there is fluid around the tendons, the structures become easily identifiable. And then posterior tenosynovitis on the medial aspect. In the longitudinal view, this is the tendon, and this is the synovial proliferation. The stars, parasitic, they are the synovial proliferation. And when we give color, the synovial proliferation takes up the color. So there is synovial proliferation which is vascular. So when you do ultrasonography of the ankle joint, the effusion, tenosynovitis, they become very easy to identify. And then coming to the Achilles tendon, this is a panoramic view. Panoramic view means that you take small ones, just like camera. You take small photographs and the join together. Similarly, in ultrasonography machine, there is something called panoramic settings are there. If you give panorama, then whole thing can be, say, 2 seconds or 3 seconds swipe of the probe, that can be, whole thing can be imaged together. Normally, when we do ultrasound, we join the images mentally. But if the panoramic facility is there, that we can do this kind of, get this kind of image. So this is back of the heel, this is skin, subcutaneous tissue, and this is the tendon. So this thickness is the tendon, and a little bit above this is the calcaneum bone. A little bit above the tendon, the swelling is there. Tendon is swollen, hypoepic, and this is called tendinopathy. So sometimes there is injury to the tendon, or there can be with degeneration of the tendon also. So that can be tendinopathy. Basically, there is the orthopedic problem, not our problem. Coming to our problem of tendinoachillitis, this is calcaneus bone, this is the tendon, and you get effusion here. Fluid is there, and because of fluid, you are getting this kind of acoustic shadow here. So this is retrocalcaneal bursitis, and this tendon, when you look in the cross section, normal tendon looks like this. It will be oval, looks like this. When it becomes swollen and rounded, when there is tendinoachillitis, the normal heart tendon becomes swollen, rounded, hypoepic, or become heterogeneous. And when you give color, they take color. Means they become vascular. Normally, tendon is avascular structure, but in case of tendinoachillitis or tendinitis, it becomes vascular. It takes up color. So this is the normal retrocalcaneal bursa. So this is skin, subcutaneous tissue. This is the tendon marked by T, and this is the calcaneum bone, and the normal bursa is here. So just a chink of fluid is there. That is the normal littoral bursa. When you get fluid here. So there is little bit more collections here. And if you see this picture, there is a vessel there. The vessels are on the periphery of the bursa. If there is bursitis, there is inflammation of the bursa. So that's why you are getting the blood vessels here. So there is retrocalcaneal bursitis. Now this joint, subplar joint, is very important because patients of rheumatoid sometimes they have got the foot pain and we are not able to understand. So next time when you see a patient with foot pain, you try to look at the subplar joint. Subplar joint is below the talus, so talocalcaneal joint, anterior as well as posterior. And sometimes patients have got this joint pathology. If you visit, you will not be able to understand why the patient is having pain. So when you see a patient next time, foot pain, you try to look at the subplar joint in the X-ray. And if the patient has got unilateral pathology, you have got, if you get X-ray done of the both the feet, you can compare also very well. So all the time, when you get X-ray foot done or X-ray hand done, we get X-ray of the both hands done, X-ray of both feet done together. Now, when you look at the posterior subtalar joint, talocalcaneal joint, you can go from posterior aspect, and this is the joint here by the arrowhead. And if you get effusion here, we can inject here. So only if there is another picture, if you get effusion like this, unless you inject into the joint, you will not get much relief. So that is very important. Though not very common, but you will get occasional patients. You will have foot pain. If you fail to recognize this posterior subtalar joint, then you will not be able to give relief to the patient. Coming, the foot pathologies are similar: arthritis, Tenocynovitis, crystal disease, and that may be plantar fasciitis also. And Motos Dunoma, something I will talk about. No, they're not common in our country probably, but it's an important cause of foot pain. Midfoot arthritis is talocalcaneal arthritis, so talonavicular talocuboid arthritis or calcaneocuboid arthritis. And you get diffusion there, and sometimes patient complains of pain in the midfoot, and again the injection is given there. So this is the midfoot arthritis. When you give color in the Doppler, you get the vascularity there, and if you give injection here, you can give good relief to the patients. Crystal arthritis in the crystal, you all know that you can go look at the DC sign, you can look at 2-5, you can look at hyperechoic spots for gout. I will show you by picture. This is a schematic diagram. The normal femoral condyle, femoral trochlear condyle, and then you get the cartilage, top of the cartilage, you get a line like this, thin line. But when you get uric acid deposition, line becomes as thick as the cortex. So normally, this is the patient of chronic gouty arthritis. So in the knee joint, you get, this is the cortex of the trochlea, femoral trochlea, and this is the top of the cartilage. So the cartilage, the crystals are deposited here, uric acid crystals, and they are as thick as the bony cortex. And not only they are thick, but they are also irregular, also not very sharp. So this is typical DC sign of one of our patients. And if you look at the MTP joints, it's look like this. So this is the bony, the MTP head cortex, and this is the DC sign. This is the longitudinal axis. This is transverse axis. So that is how we diagnose gout. Basically, these are all known patients of gout in whom ultrasound was done. And then you can get this kind of white sugar clump appearance. Basically, they have to find. And in the fluid of the uric acid crystal patient, you can get this kind of sonostone appearance. They are basically uric acid crystals, which are shown as sonostone. CUPD crystals deposit within the substance of the cartilage. So if in the gout it is deposited on the top of the cartilage, in CPPD they get deposited in the substance of the cartilage. And these are the photographs we have taken from the books. We have a couple of patients, but the photographs are not that representative. So if this is gout on the top of the cartilage, the crystals are deposited here within the substance of the cartilage. It is deposited. Another picture. So this is gout, and this is the deposition here by dot lines is CPPD crystals. This photograph we have taken from the textbook. And we know that the USG is there in the classification criteria of gout. Plantar fasciitis, one of the most common cause of sole pain or heel pain, and most of the time it is mechanical, but mechanical because we are all the time working on the hard surface, and so we tend to get pain in the sole. So that is the common cause, but in patients of spondyloarthropathy, especially ankylosing spondylitis, you can have plantar fasciitis. So this is the plantar fascia. When you do ultrasonography, it looks like this. So there is plantar fascia is there. The plantar fascia is thick, swollen, hypoechoic. Another image. So it's a panoramic image. This is the calcaneal tuberosity. The plantar fascia is this one, and this is the lower one. So this whole thing is the thickness of the plantar fascia, and this is a normal plantar fascia. When we get plantar fasciitis, this gets thickened, it becomes hypoechoic. Plantar fascia you can diagnose most of the time clinically, and motor neuroma, in few words about it. So these are metatarsal bones, and on the ventral aspect of the sole, you get these nerves are there. You can, if there is neuroma, patient can have pain. So that is motor neuroma. And in the photograph, we get this kind of hypoechoic lesions in the ultrasonography, and if, we don't find basically it's not that common in this part of the world. We don't find many patients of motor neuroma, but still it is an important cause of shoulder pain. So I have kept it here. When you will not find anything else, but patient will be suffering from motor neuroma is a possibility. Now, Dr. Shumant already talked about that we can give, when you do ultrasonography, we can give injections. When you do ultrasonography, we can give injection whenever there is fluid. This is the wrist joint, this is radius, this is lunate, this is capitate. You see radial lunate, there is a joint. Lunocapitate, there is a joint. So wrist joint, basically, number of joints are there. So single injection here may not suffice to relieve the symptoms. And because many of the times the joints do not communicate with each other. So we need to inject the joints separately sometimes. So whatever with ultrasonography we can inject, we don't have to any specific place. We can inject wherever there is fluid, we can inject there. That is how it's so easy use-guided procedures. And I will not, Shumant already have talked about them. I now talk about the hip. Basically, hip joint ultrasonography is done to look for the hip effusion and to give intra-articular injections. So this is the hip of a child, normal hip. The femoral capital epiphysis is there, so this is femoral head, and this is the neck, and this is the capsule, anterior capsule of the joint. When there is effusion, the capsule is here, comes here, this is the effusion here. And you can give injection, like in this diagram. So this is the needle going into the joint. So this is how injection is done. Because hip is a very deep joint. When you give injections blindly, there is every chance that injection will not be successful. Will not give injection into the fluid, into the joint. So that is the main use of ultrasonography in the hips. Now leg swelling, and this diagram maybe we will be able to diagnose it. Maybe this is a Becker cyst which is protruding into the calf. But if you look at this photograph, left leg is swollen. Now, what could be the differential diagnosis? Differential diagnosis common are rupture of the Becker cyst, DVT, cellulitis. So rupture of the Becker cyst, this cyst fluid is very inflammatory. It goes into the calf, it causes inflammation. DVT also causes inflammation, swelling. Cellulitis also causes inflammation, swelling. So difficult to distinguish. But if you do ultrasonography and Doppler, we can differentiate very easily. Like this patient, this is the popliteal fossa, and you can see the popliteal or Becker cyst here. And this cyst is basically ruptured cyst. So it can be diagnosed like that. Popliteal vein thrombosis, you can see the thrombus here, and if you do Doppler, you will see that the lack of blood flow, little blood flow in the popliteal vein. This is popliteal artery by the side. So popliteal vein thrombosis. Cellulitis, you get this is skin, subcutaneous tissue, this is muscle. So skin, subcutaneous tissue, you will get this kind of cobblestone appearance. And if you do Doppler, you will get vascularity here, lot of vascularity here because of inflammation. So when there is leg swelling like this, but the common differential diagnosis are rupture, Becker cyst, DVT, cellulitis, they cannot be, you can exclude them with confidence if you do ultrasonography. And you can take ultrasonography as a part of your, as an extension of your clinical examination. And a few words about the recent advance on the 2 slides. We can have USG image with MRI and CT image. So with USG, basically you get a lot of amplification. You get whatever structure is visible in ultrasonography is visible with a lot of resolution. And we get the vascularity. You can see vascularity very well with ultrasonography, and that image can be fused with MI or CT image to give a lot of information. That is an advancement in the USG. Another is 3D, three-dimensional ultrasonography. And first one is two-dimensional, the conventional which we use. This is 3D probe. The advantage is that the two-dimensional is a lot depends on the operator. So all the time move the probes, and three-dimensional probe is kept in a specified position, so it becomes more objective. So with the three-dimensional ultrasonography, maybe we'll be having more objective image of the joints, and the image looks like this. This is the black and white of BMOR, and this is the Doppler mode. The Doppler you can see the blood vessels, and probably maybe we're using the clinical trials where they need some kind of standardized pictures, and that we can get from the 3D ultrasound probes. So that's all.
Thank you, Parashar.
Yes, sir.
And any comments, Professor Alkedu?
No, these are very useful informations and which would require to be translated in daily clinical practice. At least these are the beginning of the modalities through which we can look toward the rheumatology practice at this moment. And residents, if they can utilize these modalities from the basic concepts through the advanced concepts, they can come to conclusion in majority of the time. So I feel the students are really exhausted with all information which they got. So I think if you are really interested, you can send questions directly to their mail or to Orgo, and we can keep feedback to you and give your comments so that everybody will be benefited.
Why sacroiliac joint is not accessible that much to ultrasound? Have people studied the sacroiliac joint? I was just curious.
I think Shumantha can take up that question. So basically, he's a radiologist also. He had got a degree in radiology, and he does.
Somewhere I was told that it's very superficial and that so it's difficult to sort of.
It can be seen. It can be seen. I have seen him doing SI joint ultrasonography. It requires some a radiologist basically, not a rheumatologist. Shumantha, can you comment?
Shumantha,
yes,
yeah.
yes, sir. The basic reason is due to the complexity of the joint plane, because as already Anita ma'am shared that it is actually an oblique joint. So we already have started scanning of the SI joint and published an article regarding the finding of the SI sacroilitis, the sort of in non-radiographic axial SPA patient, where ultrasonography was used to scan the joint. We also use it for the USG guided injection. The major problem is the lower portion of the joint is somewhat difficult to scan, and especially if the patient is fatty, there is more problem. In that case, you have to use on curvilinear probe. But it can be a good alternative, and some of the studies are already published regarding the SI joint ultrasound. Few studies also published regarding the use of contrast-induced enhanced ultrasound. So it is not impossible at all.
Yeah, because that would be very useful for our. So I think tomorrow is going to be a very interesting discussion on pathology by Dr. Ritambara. We'll start at 6:30, followed by she's going to talk on renal histology, and then there is in between a panel discussion, I think, of involving the fellows on the clinical decision making in management, and then lastly again Dr. Ritambara from PGI is going to speak on nerve, muscle, and histopathology of salivary gland. I think these are very useful for to see the slides ourselves. It's a great learning exercise. So the only request is that we have only about 38 people now remaining, but that please come on time, because as you see, since we start late, we also have to extend it a bit more. So at 6:15, 6:30, it's just the faculty which is normally there. So try and join in as early as possible so that we can finish early. And we'll see how we can. Tomorrow, Professor Danda is going to be the expert, the chairperson. I must thank all the speakers today for the excellent, starting with the pulmonologist, Dr. Kundu, and then Dr. Shaumindra, our own Dr. Parashar from PGI, and from KOLKATA, and especially Dr. Anandita from PGI. I think it was a brilliant, just that the topic was too vast. Some way involve the audience. So I think those who are going to interact more over all these sessions and ask more questions, Professor Alkedu has decided that we will give 5 prizes to the first 5 who maximally involve themselves. we'll see that they get some kind of credit. So please try and keep writing in the question answer in the chat box. Any comments you have, everybody is welcome. So with that, I think we'll end today, sir. And tomorrow,
Yeah.
6:30.
Tomorrow 6:30
Please
will be
log in
meeting.
5-10 minutes earlier. It's going to be very
Yeah.
interesting, sir. Thank you, Parashar. Thank you.
Thanks.
Thank you,
Thank you
sir.
very much.
Thank you. Good
Thanks
night,
to all
sir.
of you. Good night.